Shall we start?
Yeah, please.
دكتور.
بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. It's my pleasure on behalf of the Department of Oncology in Prince Sultan Medical City to welcome everybody today on the 4th of December to our Best of Oncology Care Conference. We were hoping that to run it in a live meeting, but the current circumstances of COVID-19 force us to go in the virtual way. However, I hope in these coming 2 days, inshallah, would be very richful. We are glad to have a lot of international world figure as well as national figure speakers. We're going to cover most of the topics in the slide: GI, breast, lung, etc. I'd like also to special thanks to the scientific committee led by Dr. Mirvet Mahrouz, Dr. Majdi Qandil, Dr. Osama Murshid, Dr. Talib Khrig, and the rest of the oncology department in Prince Sultan City. I also would like to thank all the partners from the sponsoring companies and also for the organizing company event troop. Just to go directly to start with, the first session will be the GI session. The moderator will be Dr. Majdi Qandil, who is a professor in oncology in Cairo University, and he's also attending consultant in Prince Sultan Medical City. Dr. Walid Sloui, he's an attending consultant in King Fahd Specialized Hospital in Dammam. Tfadal. Go ahead. Please, for every other one, just to mute their microphones. The questions would be written in the QA, and the moderator will read them after the sessions. Thank you.
Thank you, Dr. Abdulaziz, for your introduction. So without delay, I will introduce first speaker, Dr. Kanaan Al-Shammari. He's a consultant medical oncologist at the Ministry of National Guard Health Affairs. He is specialized in GI oncology and sarcoma. He will tell us how to treat rectal cancer in 2020. Please, Dr. Kanaan.
Thank you, Dr. Majdi. Thank you, Dr. Abdulaziz. And I thank the organizing committee for arranging a wonderful event, inshallah. So I'm sharing my screen now. Is everyone able to see my screen?
Yes. Yes.
Great. So Bismillah ar-Rahman ar-Rahim. Good afternoon to everyone. So I was given the task to talk about how to treat rectal cancer in 2020. I do believe that this topic has changed significantly with the latest updates in ASCO and ESMO, and I hope to summarize those updates in this presentation. So the overview of my presentation is going to be the following. I'll be talking about some historical rectal cancer trials, and the goal of talking about those is to actually introduce to you the evolving or the changing questions and outcomes that have been developed over time, which led to the TNT studies. I'm going to spend some time talking about those. I'll be talking about some upcoming or new directions, some new updates on where rectal cancer therapy is going, and then I'll end by concluding the results of the major trials. So historical standard of care is basically based on landmark phase 3 trials. Standards of care has always been long course chemoradiotherapy, followed by surgery, followed by a few months of adjuvant chemotherapy. Or it has been short course preoperative followed by surgery, plus minus post-operative chemo, which can be controversial, and this is basically probably the European school approach. So a bit of historical background. Surgery has always been upfront in the past. Then came the development of total mesorectal excision, which has improved local recurrence outcomes. Older trials try to incorporate radiation peri-operatively. There was the Dutch TME trial, which looked at short course radiation followed by TME randomized against TME. So this was the study schema. Large number of patients, all trial published in 2001 in New England Journal of Medicine. They basically randomized patients into surgery upfront, which was total mesorectal excision, as opposed to short course radiotherapy. And with significant median follow-up, the local relapse rate was significantly reduced in the group that was given radiotherapy, and no change in overall survival. So another landmark trial was the AIO-94, which incorporated chemotherapy to radiotherapy and looked at whether this is beneficial either pre-op or post-operative. And there was a significant reduction in local recurrence. So this was the study schema again. It was randomized to either giving chemoradiation pre-operatively, followed by surgery, followed by post-operative chemotherapy, compared to going for surgery, followed by chemoradiation. So when we look at loco-regional recurrences, the pre-operative chemoradiation basically group had half of the loco-regional recurrences. So the reduction was statistically significant and clinically meaningful. And this was basically a standard of care from that time. Now, in terms of overall survival, long period of follow-up, 10 years, there was no statistical significance. When we compare the two trials, the Dutch TME trial, which looked at short course radiation prior to surgery, and the AIO-94, which incorporated chemotherapy to radiotherapy pre or post-op, we can see that both of these trials have had significant reductions in local recurrence. When we look at the distance recurrence numbers, no major difference. In fact, the lines are almost on top of each other. So when we look at other trials, and look at basically patterns of failure and historical neoadjuvant trials in rectal cancer, we can see that the distant metastases have always been the failures in such trials, and that they have not basically improved distant metastatic disease. There were major improvements in local failure numbers. So the next question that came up historically is, what if we give preoperative radiation or chemoradiation, so long or short? Does delaying surgery improve the pathological complete response rate, or does it worsen our distant metastatic rate outcomes? So Stockholm 3 came about, and Stockholm 3 basically randomized patients into 3 groups: short course radiation followed by immediate surgery versus short course radiation followed by delayed surgery, and then the long course radiation followed by delayed surgery. And the primary endpoint was time to local recurrence. So in terms of distant metastatic disease, again, disappointing, no major difference. And there were basically also similar outcomes in Stockholm 2. So basically the incidence in terms of local recurrence in the whole trial was no different. However, the major difference was in the PCR rate, with major reduction when you actually delay surgery. And there was no increase in metastases when we delayed surgery. So delay resulted in better PCR response and no worsening in metastatic disease. And surgical morbidity was also better. So the next question came about, so we were delaying surgeries now for better PCR rates, less surgical morbidity. So this delay in time, resulted in better surgical morbidity and better PCR rates. Can we actually fill this wait time with some chemotherapy to achieve better outcomes? Polish 2 trial came about. Basically took locally advanced rectal adenocarcinoma patients, randomized them into short course radiotherapy, followed by 3 FOLFOX chemotherapies in this time delay, compared to long course chemoradiotherapy, and they actually used oxaliplatin. And the primary endpoint was microscopically radical resection rate R0. Now, when we look at the results, overall toxicity was actually better when you incorporated some chemotherapy prior to surgery and you gave short course radiotherapy. And when we look at the PCR rates here, there was a trend towards better PCR rate when you actually incorporate some chemotherapy as well. However, this was not statistically significant. So since these prior trials that I've presented, there hasn't been any published trial that was successful in telling us that there was an improvement in overall survival. About 30% still develop distant metastatic disease, and compliance to post-operative adjuvant chemotherapy was poor. Compliance to neoadjuvant chemotherapy has been shown to be better in phase 2 trials. So then this concept of TNT, or total neoadjuvant therapy, came about. So if we actually believe that systemic chemotherapy is beneficial in patients with rectal cancer, why don't we give it all prior to surgery? So I guess potential benefits of TNT are: you treat subclinical micrometastases early, you enhance response to the primary tumor, and I think I've shown this in prior trials, that PCR rates are better. You improve treatment compliance. This was based on a few phase 2 trials. There are 2 ways of giving TNT, either as induction, meaning prior to radiation or chemoradiation, or after radiation or chemoradiation as what is known as consolidation. Now, potential problems or complications with TNT, there is a potential for hastening tumor repopulation by selecting resistant clones, and it may impact on compliance to chemoradiation. So as I mentioned before, 2 options. One is induction, meaning chemotherapy prior to short or long course radiotherapy, followed by surgery, or consolidation, meaning you start with short course or long course chemoradiotherapy, followed by the consolidation chemotherapy, followed by TME. So let's talk about the Prodigy 23. So this was a big trial. Basically, they randomized patients into giving FOLFIRINOX chemotherapy, followed by chemoradiation, followed by total mesorectal excision, followed by adjuvant chemotherapy, as opposed to the standard of care, which is upfront chemoradiotherapy, followed by TME, followed by adjuvant chemotherapy. Primary endpoint was disease-free survival. This is another basically picture of the study or the protocol schema. And what I wanted to show you here is that they gave 6 cycles or 3 months of FOLFIRINOX as neoadjuvant, followed by long course chemoradiotherapy, followed by a 7-week wait, and total mesorectal excision, followed by 3 months of FOLFOX. So when we look at baseline characteristics, I'm not going to spend time on this. They are basically almost identical. Now, when we look at the pathology findings, we can see that the TNT group, so ones who were given neoadjuvant FOLFIRINOX, have had significant tumor regression as opposed to the standard of care chemoradiotherapy followed by surgery. Now, disease-free survival was also statistically significant and clinically meaningful in the experimental group, so ones that were given FOLFIRINOX neoadjuvantly, with a 3-year DFS rate of 75.7% as opposed to 68.5%, with a decent hazard ratio of 0.69 and a statistically significant p-value. Now, when we look at other endpoints, so DFS and metastatic free survival, that's also an important endpoint, were both statistically significant in the experimental arm, so the total neoadjuvant arm, and you had significantly better tumor regression rates. In terms of safety, overall incidence, so grades 1, 2, 3, and 4, were worse in the standard of care and were actually better overall in the TNT group. Of course, as you expect, with giving more oxaliplatinum-based chemotherapy, you did have significantly more peripheral neuropathy in the TNT group. So, conclusions from the Protégé 23 trial. This was the investigator's conclusion. It did demonstrate feasibility of administering neoadjuvant FOLFIRINOX in stages 2 and 3 rectal cancer. And administering it prior to chemoradiation did increase the probability of pathological complete response and did show a statistically significant and clinically meaningful improvement in DFS and metastatic free survival. So the investigators concluded that TNT with modified FOLFIRINOX should be considered the new standard of care. Another major trial was the Rapido trial, which basically looked at giving short course radiotherapy, so 25 gray in 5 days, followed by 4.5 months of chemotherapy in the form of CAPOX, followed by TME, as opposed to the standard of care, which is chemoradiotherapy, which is the prolonged course, followed by an 8-week wait, followed by total mesorectal excision. Now, they did take, if you look at the inclusion criteria, basically advanced patients, so T4, N2 threatened CRM margin. When we look at chemotherapy compliance, significantly better on the left-hand side in the pre-operative chemotherapy as opposed to post-operative chemotherapy. When we look at pathological outcomes, significantly better in the experimental arm, so patients who had 6 cycles of CAPOX prior to surgery, and this was in 28% of patients, as opposed to half of that in the standard arm, which is chemoradiation followed by 8-week wait followed by TME. Now, when we look at this distant metastatic rates, also, just like Protégé, the experimental arm was superior here with a almost 7% reduction rate with a decent hazard ratio of 0.69. When we look at overall survival, not a major difference. Now, in terms of acute toxicity, grades 3 and 4 were worse in the experimental arm when you gave 4.5 months of CAPOX prior to surgery. So I guess from Protégé and from the Rapido trials, we can say that neoadjuvant chemotherapy with systemic doses for 3 to 4 months duration did reduce the risk of metastases. So we did have 2 trials that were large that did give us proof of principle of this concept, that if you give chemotherapy prior to surgery, that you are going to improve or reduce the risk of metastases. The reduction was approximately 7% in both trials, although they were different populations. The Rapido trial did take quite extensive and advanced disease patients. No significant difference in 3-year overall survival. Now, the OPRA trial was also an interesting trial that I want to spend just a little bit of time on. So basically, this trial wanted to see wanted to compare the investigational arm to the historical arm. Historical arm, we all know it, the chemoradiation followed by wait, followed by TME, as opposed to 2 different arms in the investigational arm, one comparing the induction chemo, the other one comparing consolidation chemo, to see if you can preserve basically the organ. So whether you can reach the watchful waiting approach when you reach a clinical complete response. So when we look at the DFS, so this trial was not really designed to compare the two arms of induction versus consolidation chemo. It was rather trying to compare the experimental arm, so those two sub-arms compared to the standard of care chemoradiation followed by TME. So no significant difference whether you give induction chemo versus consolidation chemo in the DFS. However, there was a difference in total mesorectal excision-free outcome, so organ preservation, and this was superior in the basically consolidation arm. So to summarize the findings of Prodigy, OPERA, basically, and the Rapido trials, when we compare TNT to standard therapy being chemoradiation followed by TME, followed by intended post-operative adjuvant chemotherapy, TNT was found to be associated with higher compliance with systemic chemotherapy, a bit more toxicity. There was a significant reduction in distant metastatic rate. There was a possible improvement in disease-free survival. There was not a significant improvement in overall survival and no significant effect on local tumor control. TNT may overtreat some patients and add toxicity. This is evidenced by significant tumor reduction. There was increased tumor response, as I mentioned, specifically when chemoradiation is followed by consolidation chemotherapy, and I think I've shown this in the OPERA trial. It could potentially benefit patients who get a clinical complete response if they are entered in a watchful waiting approach as per OPERA. Now, I guess this is the exciting part of rectal cancer. Now, this is the Voltage A study, which is a Japanese trial that looked at incorporating immunotherapy in advanced or locally advanced rectal adenocarcinoma patients. So background to this, I think we all know how PD-1, PD-L1 inhibitors work. Radiotherapy does release neoantigens and can augment the effect of immunotherapy. And I think this is the basis of this trial happening. Immunotherapy is active in MMR deficient tumors and has limited activity in microsatellite stable or proficient MMR tumors. So apologize about the complex schema here. However, in summary, basically they've taken resectable primary rectal cancers and have given them the standard of care preoperative long course chemoradiotherapy with capecitabine. And then they have divided them up into two groups. Cohort number 1 were MSI stable patients. Cohort number 2 was MSI high patients, and have given them up to 5 cycles of nivolumab. And of course, this is followed by radical surgery. So just a brief background about MMR or MSI high rectal cancers. So prevalence in rectal cancer patients varies between 2 to 12%. And it basically is reflected by what testing method you use. Deficient MMR or MSI high patients with neoadjuvant chemotherapy. From the Memorial Sloan Kettering data, there were a few patients with rectal cancer that have progressed on neoadjuvant chemotherapy. So when we look at this trial and patient characteristics, now I want to show you, so what's the red circle here? When we look at the N category, so the N0 patients, 30 patients out of 39 patients in cohort A1. So this is the MSI stable patients. Most of them were N0 patients. So that comes out to being 77% were clinical node 0. Whereas when we look at other trials, most other phase 3 trials had about 40% N0 patients. So they did select a early group of patients. Also, when we look at the T category, just above the red circle, 34 patients out of 39, so the majority had T3 and very few had T4 disease. Now, when we look at the pathological response, so PCR rates, surprisingly, 30% of patients who were MSI stable or proficient MMR had PCR when they had nivolumab after chemoradiation. So that's a rather large number for MS stable patients, whereas 60% of a small cohort that were MSI high had PCR in that group. Now, this is the exciting biomarker slide. Now, when we look at biomarkers that were used by the investigators, we look at PD-L1 expression, we look at CD8 / ETREG in tumor infiltrating lymphocytes in expression, and we look at the combination of those biomarkers in the table on the right-hand side. So when we look at the top left corner, so patients that were PD-L1 expressors of more than 1%, and I have to note there are different testing methods of PD-L1, and the ones that was used in this trial was the IHC 28-8 PharmDX kit. So PD-L1 expressors that were more than 1% in cohort A1, so this is the MSI stable patients, they had 60% PCR rate, as opposed to PD-L1 less than 1% that were 19% rate.
2 minutes, please.
Sure, I will conclude shortly, Dr. Majdi. So when we look at the right-hand side table, when we look at patients who have PD-L1 expression of more than 1% and the CD8 ETREG ratio of more than 2.3, so high expressors of CD8, if we actually combine both of these both of these biomarkers, 100% of those patients in cohort A1, so MSI stable patients, had PCR. So very exciting indeed. So conclusion to this new trial is that there were promising PCR rates of 30% and 60% in MSS and MSI high patients that were treated with nivolumab, followed by radical surgery after chemoradiation, and it was associated with very mild toxicity. However, to note, these were early patients. PD-L1 expression and elevated CD8 ETREG ratio could be a predictor for PCR. And by that, I conclude. Thank you very much.
Thank you, Dr. Kanaan. Can you stop sharing, please?
Of course.
Thank you for your elegant presentation. We'll go for the next speaker, Professor Sylvie Lorenzen. Professor Sylvie is a professor of medical oncology at München University. She has great experience in GI oncology with more than 76 topics of research and more than 1,692 citations. She will tell us 2 lectures. The first one, the role of immunotherapy in MSI high metastatic colorectal cancer. And the second lecture will be the new exciting data of immunotherapy in advanced gastric and gastroesophageal junction cancer. Please, Dr. Sylvie, go ahead.
Thank you very much, Dr. Kendall, for this really nice introduction. It's really a pleasure to give a talk about immunotherapy in MSI high metastatic colorectal cancer. And time to start, the title is at the right moment, because just yesterday, the New England Journal paper of the Keynote 177 trial was published. So I think it's perfect timing to give this talk. So looking at the quiet historical ESMO recommendation from Eric van Kutsem in the Annals of Oncology 2016, you see here what is our recommended treatment algorithm in metastatic colorectal cancer. However, molecular profile like MSI is not already mentioned, and therefore I think the ESMO recommendations need a urgent update, because now we have the evidence, and with the paper and the publication we also have the proof. So starting from the role of MSI in metastatic colorectal cancer, and coming from an era before immunotherapy and no BRAF inhibition, you see that the prognosis is much better for MSI high tumors compared to MSS tumors, and it's the best for MSI high and BRAF wild type tumors. So you all know the background of how it works, that tumors become MSI high. We know in colorectal cancer, about, depending on the stage, 10 to 15% are MSI high. From these 15%, about 12% are sporadic MSI, and these also often carry BRAF mutations, whereas the hereditary MSI high tumors only count for about 3%, and they are usually BRAF wild type. So I'm not going too deeply into background. You all know that extensive insertion and deletions in coding regions leads to frame shift mutations, and they are not able to repair these mutations anymore. And what we are getting is a generation of unique new antigens and increased immune tolerance by PD-L1 expression. With regard to the diagnostics, we usually test for 4 enzymes. The first testing is immunohistochemistry. We all know that MLH1 is in the sporadic cancers usually methylated, whereas for the hereditary we have usually MLH1 and MSH2. So in terms of patients where there is unclear immunohistochemistry result, a PCR to determine length of microsatellites is recommended. And for that, I show you here the treatment or the test algorithm. Immunohistochemistry is usually done for all 4 enzymes, and if immunohistochemistry is unclear, and specifically in young age or HNPCC criteria, where a hereditary MSI tumor is expected, a PCR for MSI status is highly recommended. So where are we coming from? In the last years, couple of phase 2-3 trials in pre-treated MSI high patients were published for both agents, nivolumab and pembrolizumab, and it has been shown that in MMR deficient colorectal cancer, you see here, these are very small numbers, the immune checkpoint inhibition can reach really high response rates with up to 60% compared to 0 if the tumor is MMR proficient. And also disease control rates up to 90% with progression and overall survivals not reached at this time of publication. So looking at the second line setting for MSI high tumors, you see here what can we expect with either nivolumab or pembrolizumab based on these trials. We see kind of objective response rates about 30% and 1-year survival rates of about 70%. So this is quite clear, and this is there's no big difference which immunotherapy you use in these patients. One of the landmark trials is the 3-cohort Checkmate 142 trial. It looks like a randomized trial, but it isn't, because there were just 3 independently recruiting cohorts. 2 cohorts in the second line or third line setting with either nivo or nivo-ipi as a combination therapy, or there was 1 cohort in the front line looking at the combination of nivo-ipi, all in MSI high tumors, and the primary endpoint of all cohorts was the objective response rates by investigator assessment. So what have been shown? we see in patients with at least 2 prior lines of therapy, we see about 60% of response rates with the combination. Remember, with the monotherapy, we reach about 30%, and we also see an increase in the overall survival rate after 1 year, from about 70 to 85, so another 10% increase if we use the combination, not only with nivolumab, but with the addition of ipilimumab. And here again, you see this was published by Overman in the JCO 2018. Really good response rates in the waterfall plot. And if you look at progression-free and overall survival, really encouraging rates with and it seems like even if patients receive it in later lines, they have a great chance to reach a plateau. Here, I want to show you again the 2 cohorts in the 2nd and 3rd line setting with either nivolumab or the combination, showing that response rates are increased when you give the combination. And it also might be that the survival, both progression-free and overall survival, are prolonged. And this is something you shouldn't do, but it was done to look at the 2 cohorts like in a randomized trial. And this shows clearly that the benefit of the combination is clearly higher in terms of progression-free and also overall survival for the combination compared to nivolumab monotherapy in the 2nd and 3rd line setting. There was another trial, a KEYNOTE 164 trial with pembrolizumab, also in pretreated patients with MSI-high metastatic colorectal cancer. And what you can see here, they looked if there is a difference if you give it in classic 2nd line or if you give it in 3rd or 4th line. And as you can see here, response rates are pretty much the same, 33%. However, progression-free and overall survival seem to be prolonged the earlier the better you give the immunotherapy in MSI tumors. So here again, you see the red curves for 2nd line treatment and the blue curves all for progression-free and overall survival after 2 or more lines of therapy. And you see there is a slight increase in overall and progression-free survival if you give it the earlier the better. And this brings me now to the 1st line cohort, looking at the combination of nivo-ipi, primary objective, still objective response rate. And here you can see even an increased response rate with 60% and also progression-free and overall survival rates, with survival rates of 15 months, 75%, 15 months, survival 84%. And you see there is not a big difference if you look at the survival rates at 12 or 15 months. So we really hope that these patients do have a long-term benefit from immunotherapy in this setting. Well, and this is the breaking news now, the recently, well, yesterday, publication in the New England Journal of Medicine of the KEYNOTE 177 trial, which was a late-breaking abstract this year virtual ESCO meeting. And the background for this trial was that about 5% of all our metastatic colorectal cancer patients have an MSI-high tumor. We know that MMR deficiency or MSI-high is predictive for the efficacy of immunotherapy in further lines with either pembrolizumab or nivolumab, which has been shown in phase 2 trials. And therefore pembrolizumab, but also nivolumab, is FDA approved in the further line setting. So you all might know this design of the KEYNOTE 177 trial, the biggest trial we ever had in MSI-high tumors with more than 150 patients per arm, randomizing patients in either pembrolizumab monotherapy or investigator's choice chemotherapy, usually a doublet plus minus an antibody. A triplet therapy was an exclusion criteria. And it is important to know that there was an optional crossover to the experimental arm with pembrolizumab after progression of disease in the chemotherapy arm. There was a dual primary endpoint. It was progression-free and overall survival. And according to the statistics of this trial, one positive endpoint was enough to make this trial a positive trial. Here you see the baseline characteristics of the KEYNOTE-177 trial. Interestingly, the majority of patients were from Western Europe or North America. Only about 14% were from Asia. Also interesting is that about 2/3 of patients had a primary tumor location in the right side, which we expect because we know that right-sided tumors usually have higher rates of BRAF mutation than MSI tumors. But, however, I also have to say that left-sided tumors had an MSI high tumor in 30%. And this is quite high and more than we expect, and also should tell us that we have also to test left-sided tumors on MSI. Also interesting, the rate of BRAF or RAS mutated tumors, both about 20 to 25%, and both arms were equally balanced according to BRAF and RAS status. So this is the first and only primary endpoint which has been reported until now. Also, it is the other primary endpoint, overall survival, is not reported in the publication. So we have to live until now with the progression-free survival, and what you can see here, there was a clear statistically significant improvement with a doubling of the progression-free survival from 8 to 16.5 months. And what this curve also show us, that with 8.2 months progression-free survival, the chemo arm is less than what we expect in MSS tumors. So MSI high tumors do worse with chemotherapy compared to MSS tumors. And what these curves also tell us, there's a crossing of the curve between 7 and 8 months. So we have not very small proportion of patients who are primarily progressive on immunotherapy, although they have an MSI tumor. Objective response rates, 44% compared to 33% with chemotherapy. And also this tells us that chemotherapy in terms of objective response rate is worse than what we expect from chemotherapy in MSS patients. So this is something I copy-paste from the original publication. These are the subgroup analysis for progression-free survival. And interestingly, you see here that independent of the BRAF status, there was the same benefit for immunotherapy with almost identical hazard ratios. So if you have an MSI, BRAF mutant tumor, which is usually a sporadic tumor, you should start with immunotherapy and not with a BRAF inhibitor or a triplet chemotherapy. Also interesting is how RAS mutant tumors, and as told you already that this proportion was about 22%, they seem not to benefit from immune checkpoint therapy. And this can be anticipated that it might be this group of patients who do worse at the beginning and they do not benefit from immunotherapy upfront. But we have also the cohort in the CheckMate 142 trial. Although these were only 45 patients, we see in the indirect comparison that it seems to be more beneficial if you give the double checkpoint Nivo and Ipi, looking at the CheckMate 142 12 months progression-free and 24 months progression-free survival rate, which was clinically meaningful higher compared to the KEYNOTE-177 trial, with 76% for CheckMate and only 55% in the KEYNOTE trial. However, this is something which isn't really allowed as a cross-trial comparison, but we should keep in mind that the doublet with Nivo-Ipi seems to be better than the Pembro monotherapy, although the evidence is much better for the KEYNOTE-177 trial. Looking at the tumor response, I showed you already that we have a progression rate of about 30% compared to only 12% with chemotherapy only. And however, response duration for patients who do respond is very long, longer than 24 months in about 83% of patients compared to only 35% with chemotherapy. Looking at the waterfall plots here, this is just to make it more obvious that, of course, we have more objective response rates with the pembro therapy if you give it upfront compared to chemotherapy. However, but we have to look also at the checkmate trial with nivo-ipi, and what you can see here, objective response rates was between 58 and 64%, depending on the assessment form, which is again higher than in the Keynote 177 trial. And more important, the progression rate is comparable to what we see with chemotherapy in the Keynote 177 trial. It's only 13%. So the question is, if I have a young patient with limited metastatic disease, MSI high tumor, where we want to have, want to be very sure that tumor shrinkage is obtained and the patient has maybe a chance for secondary resection, if you not rather go for nivo-ipi as the more effective regimen, at least in terms of response rate, and do not risk a 30% progression rate in these patients. Or we think of RAS mutational status and say, oh, RAS mutated tumors should rather not be treated with pembro mono rather than with nivo-ipi. So here again, you see what achieved in the Checkmate 142 trial with up to 84% of patients showing a reduction in tumor burden compared to baseline. And already shown response duration for patients who responded was really promising and something which we have never seen before in this patient population. With regard to toxicity, you see here that the tolerability was much better compared to chemotherapy. Grade 3/4 toxicity, only 22% compared to 66% with chemotherapy. And this also was reflected in the better quality of life, looking at the week 18 score, where we can see that the quality of life was significantly in favor for pembrolizumab, and the compliance was even better with immunotherapy compared to chemotherapy. And looking at the pre-specified functional scales, you see here improvement in orange up, and green is pembrolizumab. It's all in favor for pembrolizumab. And if you want to look into the different functional and symptom scales in detail, you see here the green lines are always better, which means a less probability for the deterioration compared to chemotherapy. And this can be shown in all different functional scales, physical functioning, quality of life in general. So is this a class effect? And this is again the comparison of the Keynote 177 and the Checkmate 142 trial. In both trials, we see an improvement in quality of life with immune checkpoint inhibitor therapy. And this in the Keynote 177 trial, although about 30% was primarily progressive. So what comes next? What about tumor mutational burden? There seemed to be a cutoff of 40 mutational mutations per megabyte, which seems to be predictive for response to immunotherapy. What about combination therapy in first line with chemotherapy? There is the COMMIT trial. Or what about the combination of nivo-ipi plus chemotherapy? I just quickly want to highlight these trials, which now I can't continue. I don't know why. Sorry. Oh, this was now very fast. Sorry, something was wrong. Sorry. I think now it works again. 1 second. I wanted to show you the COMMIT trial with atezolizumab. Until now it worked. But this, it doesn't like. Here, so sorry. The COMMIT trial is also randomizing first-line MSI high tumors in FOLFOX plus beva versus atezolizumab monotherapy versus the combination of chemoimmunotherapy plus bevacizumab. And the other trial, sorry, this is only in German and it's of courtesy of Bristol Myers Squibb, is looking in the first-line MSI high tumors comparing nivolumab, nivo-ipi, and then investigators' choice chemotherapy. So this is also a trial which is now running to see if there is the combination, maybe for RAS mutant patient, the better strategy up front. And this shows you that high mutational burden is predictive for response on immunotherapy. Again, here, tumor mutational burden high, although these are very small numbers of patients, you see they might be in favor for immunotherapy. So the interesting question is, how often do we see MSI and high tumor mutational burden? And this is an interesting paper looking at more than 60,000 specimens. And in these specimens, only 700 were MSI and TMB high, and more than 4,000 show TMB high. So what is the consequence finally? How many tumors are MSI high on total? And another question is, how many tumors have high TMB? Again, how many MSI high tumors have high TMB? Or how many with high TMB are MSI high? So coming back to the first questions, we think about 1% to 2% are MSI high, and high TMB are about 7%. So the question now together, MSI high and high TMB are 83%. So as soon they have MSI high, they also usually have a high tumor mutational burden. However, high TMB and MSI high, this is only in 16%. So there are many trials, single-arm phase 2 trials, looking at the combination in first and second line of immune checkpoint inhibitor plus chemotherapy in MSI high, but also in MSS tumors. But these are small numbers of patients, single-arm trials, and combined MSS, MSI. So they might show a signal for even better response rate if we combine, for example, FOLFOX, cetuximab plus avelumab. But of course, we're lacking phase 3 evidence at the moment, and we have to wait for these two big trials. My last point I just want to show you is that we know that kinase rearrangements are enriched in MSI high tumors. So MSI high tumors really often carry kinase rearrangements, and this should lead us that we do panel sequencing in all MSI high tumors in order to not miss, for example, FGFR2 or NTRK fusion mutations. And my last slide is for POL mutations. I think this is a very interesting subgroup of patients who have the polymerase epsilon mutation. These are usually MSS, but carry a high tumor mutational burden. And we are really lucky that we have 2 patients here with colorectal cancer. They were all resistant on all kinds of chemotherapy. Then the POL mutation was detected, and both patients are now for more than 3 years in complete remission with pembrolizumab. So POL proofreading should be looked at in the panel sequencing. So these are the final NCCN guidelines from this year. So pembrolizumab upfront in MSI high tumors is recommended, as well as nivo. We do not have the FDA approval for the combination nivo-ipi. And my summary is that we should test all patients, even non-CRC patients, by immunohistochemistry for all 4 enzymes and add PCR rate in patients with a low threshold. We should refer all MSI high patients for gene panel because we know that there is a high chance for kinase rearrangement. We should administer either PD-L1 or PD-1 immunotherapy in MSI high patients according to our local acceptors. And but maybe in patients who have a high need for response or maybe a chance for secondary resection, we have to consider about the addition of a CTLA-4 inhibitor together with the PD-L1 inhibitor. So, and the research continues to combinations with chemotherapy. We have to refine the proven efficacious immunotherapy in MSI high and find new treatment strategy specifically in the big group of MSS or proficient MMR tumors. So these are the ESMO guidelines commented by Eric van Kutsem, 2014. And yeah, in most cases, we cannot estimate how indolent the disease is, which means even MSI tumors with a good prognosis have a high chance to be progressive under immunotherapy. And for these patients, we might to find better solutions, maybe in combination with chemotherapy or with the combination of a CTLA-4 inhibitor in the future. So with this, I want to finish my first presentation on colorectal cancer. And I don't know if questions are, yeah.
We'll keep questions at the end. Thank you, Dr. Sylvie. Can you proceed for the next lecture about citing data for immunotherapy in advanced gastric and gastroesophageal cancer?
So I think you see my screen.
Yes.
Yeah?
Yes.
Perfect. So yeah, now I want to switch one stage up to what is the current status for immunotherapy in advanced gastric GE junction cancer. And I think this was a really promising year for this type of cancer and immunotherapy, which haven't been in this way before, because we had 4 late-breaking abstracts at this year's ESMO, which were positive, and I think they are also practice-changing. So quickly on the epidemiology of gastric cancer, we're talking about 1 million new cases in 2018. It's still the 5th most common malignancy worldwide, and it's the 3rd leading cause of cancer death worldwide. Unfortunately, about 40 to 80% of patients with gastric cancer already present with metastatic disease. These are the ESMO treatment recommendations, and I only want to focus on the metastatic disease. We're now talking about sequential therapy, which hadn't been the case years before, because we have approved 2nd line and now also a 3rd line options with Lonsurf available since last year. So gastric cancer is now really candidate for sequential treatment. And of course, we first test on HER2 negativity or positivity. About 15% are HER2 positive. And I want to skip these patients in today's talk and only focus now on HER2 negative patients, which have been included in these major trials. The prognosis of patients with HER2 negative disease is still really bad, with a median survival of around 1 year and 2-year survival of 10 to 20%. However, we know that chemotherapy can improve survival and also quality of life. There have been numerous attempts in phase 3 trial to improve the prognosis of these patients by adding targeted agents, but however, only 3 studies were really positive. This was the TOGA trial a long time ago, and also to the 2 second-line trials with ramucirumab, the VEGFR2 antibody, either in monotherapy or in combination with paclitaxel. All the other trials were unfortunately negative. So, but why have been targeted treatments in gastric cancer until now so less successful compared to other tumors, for example, lung, melanoma, or breast? And I think the major reason is that gastric cancer is a very heterogeneous disease. We have a high interpatient variability of histology. We have a few mixed type tumors. We have intestinally and diffuse type tumors, and they do all different depending of depending on how they were treated. And there is also intrapatient genomic heterogeneity of gastric cancer. For example, a difference between the primary tumor and the metastasis. So there is discordance in up to 30%, which means it's not only enough to test the tumor, but you should also sometimes retest the metastasis specifically after failure of treatment. Until now, we have 3 approved molecular biomarkers. The most important is HER2, but we also test for MSI and EBV. And I think in the near future, we will also test the CPS score. What we know from the Cancer Genome Atlas that we have distinct tumors, specifically in the esophagus, that squamous cell carcinoma, if you look at the molecular profile, usually behave like head and neck cancer. And we know this about the successful story of checkpoint inhibitors in squamous cell carcinoma of the head and neck, whereas adenocarcinoma usually behave like gastric cancer, and this might also be the reason for that in adenocarcinoma, the story is not as successful for checkpoint inhibitors compared to squamous cell carcinomas. So we usually look at 4 molecular distinct subgroups. If we talk about gastric cancer, we have the big group of chromosomal unstable tumors, usually located at the G junction, and also the 20% diffuse types, which are usually genomic stable. And we have the EBV or MSI high tumors, and which are usually candidates for immunotherapy. However, the incidence of these tumors is very low. So next steps, immunotherapy. What is the present? We have nivolumab approved as well as pembrolizumab in patients with CPS of more than 1 after 2 lines. And this is in the US and Japan. And we have also now the approval of pembrolizumab and nivolumab in second-line squamous cell carcinoma. Not pembrolizumab in Europe, but FDA approved. But since 2 weeks, we also have nivolumab EMA approved for second-line squamous cell carcinoma, according to the ATTRACTION-3 trial. This was the role of immunotherapy until ESMO 2020, and you see a lot of no advantage in phase 2 and 3 trials in the first line, but also in second line, in maintenance strategy, and in the last line setting with only moderate response rates of about 10%. These are the expected results from phase 2-3 trials until 2022. And I now want to focus on the 2 late breakers, the ATTRACTION-4 and the CheckMate 649 trial, which has been presented at this year's ESMO trial. The Keynote 590 trial is a mixed trial of squamous cell and adenocarcinoma, which also have been shown positive. So I want to start now with the Keynote 590 trial. Inclusion criteria were both squamous cell and type 1G junction tumors, and patients were randomized into the addition of pembrolizumab to standard cisplatin 5-FU, primary endpoint overall survival and progression-free survival, and there was no stratification according to the CPS score. Here you see the baseline characteristics. The majority was squamous cell carcinoma, only 30% had adenocarcinoma. Half of the patients were recruited in Asia, and half of the patients had a CPS score of more than 10, which is interesting. Here you see the primary endpoint improvement in all patients with the addition of pembrolizumab, but the effect was most pronounced in patients with a CPS score of more than 10, and specifically in patients with a CPS score and squamous cell carcinoma. Objective response rates for all patients was improved by 15%, and these patients who responded had a clearly prolonged duration of response with 8.3 versus 6 months. Interestingly, now looking at the subgroups, you do not see a difference between adeno and squamous cell carcinoma with regard to hazard ratios. However, patients with a CPS score of higher than 10 did benefit most, whereas patients with CPS less than 10 had a hazard ratio of only 0.86. So the conclusion is we clearly see a superior overall survival, specifically in squamous cell carcinoma with a CPS score of 10, but also in squamous cell carcinoma and in all patients. However, the effect was not as pronounced for the adenocarcinomas. And the same for progression-free survival and superior objective response rates with no new safety signals. However, we have to ask us, which subgroup benefits most? It was clearly squamous cell carcinoma with a CPS score than 10, but CPS score was not used as stratification parameter. And the impact for the adenocarcinoma, which are only GE junction type 1 tumors, seems to be contagious. Is cisplatin 5-FU the best regimen for adenocarcinomas? And are the results applicable for Caucasians? You remember Asians amounted for about 50%. So, and the most important question, how can these results be interpreted in combination with the results for the adenocarcinomas in the CheckMate 649 trial. And this is the 648 trial, which is still recruiting and is looking only for squamous cell carcinomas with nivolumab plus chemotherapy or immuno only or just chemotherapy. So we are expecting these results in 2021 or 2, and we look if this CheckMate 648 trial can confirm the positive results, at least for the squamous cell carcinomas of the Keynote trial. Coming to the CheckMate 649 trial, this was an only adenocarcinoma trial looking at nivo-ipi, immunotherapy only, or nivo in addition to chemotherapy versus chemotherapy only. And at the ESMO, only these two arms were presented with more than 1,500 patients. There is nivolumab, ipilimumab results expected for next year. So we are looking if these results might show us that nivo-ipi might be as good as the combination with chemotherapy. Here you see MSI high tumors, 4%. That's what we expect usually. And the majority of patients had gastric tumors, 70%. The agents were only in 1/4. So the primary endpoint was overall survival in CPS and more than 5. And what you can see here, the addition of nivolumab led to an increased median overall survival by 3.3 months with a hazard ratio of 0.71. There were also subgroups of patients with a CPS score of more than 1 or all randomized patients. And what you can see here, they still do benefit, but they less benefit compared to the cutoff of CPS score 5 and more. And this were about 60% of all patients. So the same was seen for progression-free survival with an improvement of progression-free survival, specifically in the patients carrying a CPS score of more than 5. So now the subgroup analysis, and I think this is very interesting because as you can see here, gastric tumors benefited the most, whereas the hazard ratio for the G-junction tumors was only 0.84. And I showed you already the G-junction tumors in the Keynote 590 trial. So we are not sure if G-junction tumors really do benefit as much as gastric or squamous cell carcinoma from the addition of immunotherapy. Of course, the 4% MSI high tumors had the most pronounced benefit, so the median overall survival in this subgroup is not reached yet. With regard to objective response rate, we saw a 15% increase in objective response rate up to 60%, and also the duration of response was in favor for the addition of immunotherapy. So in summary, nivolumab is the first PD-L1 inhibitor demonstrating superior overall survival and progression-free survival in combination with chemotherapy. And the effect was most pronounced in CPS higher than 5 patients. The survival benefit was across multiple subgroups. However, it was less aware in the G-junction tumors, and no new safety signals were identified with this new combination. So the authors of this trial say that, or conclude that nivo-chemo represents a new potential standard first line for patients with adenocarcinoma. Yeah, these are my own thoughts, and we have to question ourselves: is chemo nivolumab now the new first line standard? If yes, is it for all subgroups? Will we get the approval from the FDA, from the EMEA for all comers, or depending on the CPS score? If you look at CPS of 1 to 4 or PD-L1 negative, the hazard ratios are less in favor with 0.91 or even more than 1. This was made by a local statistician and no data shown by the authors, I must say. Well, we have the Keynote 062 trial, which was a negative trial for upfront pembrolizumab. However, these are 2 different trials and we can't really compare them, although we have to look deeper into detail with respect to second line and crossover immunotherapy patients. Well, the question if G-junction tumors benefit less than gastric cancer, And what's the reason for that, which we have seen already for the keynote trial, and we're waiting for subgroups of the keynote trial, specifically for adenocarcinomas of the G junction with a CPS score of less than 10. How often do we really see these patients? In the trial, it was 60%, but is this really that high in real life? I doubt. And of course, we're waiting for the results of the immunomonotherapy arm, which are expected in 2021. So how could these results of first-line EO therapy influence our treatment algorithm? And I think the future will be the approval of nivolumab, at least in patients with a CPS score of 5 or more. So we have to routinely test now CPS score in this patient population. For the esophageal cancer, I think squamous cell carcinoma is the tumor with the highest unmet need, and I hope that pembrolizumab will be approved independent of CPS score. Well, for the adenocarcinoma, that's what I said already, and I'm not sure about G junction type 1, if pembrolizumab will play a role here according to the results of the 590 trial. So, at last and least, I want to quickly highlight the approval of nivolumab in the second-line setting. I showed you already that there is a different molecular structure of squamous and adenocarcinoma. This is the publication of the attraction-free trial, which was to 97% an Asian trial in the Lancet Oncology, looking of nivolumab versus investigators' choice taxane treatment in the second-line treatment after platinum 5-FU-based first-line treatment. Overall survival was primary endpoint. It was a really highly selected group of patients. We participated in this trial. It was very difficult to find patients who fitted the inclusion criteria. And as we have seen in other trials with immunomonotherapy, we see a crossing of the curves around 6 months. So few patients do worse with immunotherapy compared to chemotherapy at the beginning. But in the end, they seem to benefit most, as you can see here in the subgroup analysis. And specifically, all patients benefited with nivolumab. And this also in terms of duration of response, although response was not increased between nivolumab and chemotherapy, it was around 22% for both treatment strategies. However, quality of life improved significantly with immunotherapy. So, and this is very important, specifically in this poor prognosis group in second-line squamous cell carcinoma. And here you see again for nivolumab and chemotherapy, nivolumab in blue, chemotherapy in gray, and you see here that the treatment was much better feasible with nivolumab compared to chemotherapy. So in summary, it is a trial which showed a 23% reduction in the risk of death with an improvement of 2.5 month median overall survival. However, we have a significant number of patients who do not benefit until month 6. We have, in general, 10% more patients alive after 18 months, and the survival improvement is independent of PD-L1 expression, as we usually see in nivolumab trials. Specifically, safety and tolerability was improved with nivolumab compared to chemotherapy, with a 3 times lower incidence of grade 3/4 treatment adverse events, which showed an improvement in quality of life, which was clinically relevant. So here is the EMA approval for nivolumab now as new second-line treatment. However, we have to question ourselves if this is still relevant when pembrolizumab is going to be approved in first-line treatment in combination with cisplatin 5-FU. So in summary, first-line squamous cell carcinoma, keynote 590, I hope this pembrolizumab will be the new standard in this first-line therapy, because we haven't seen any success in the last 20 years. We have nivolumab approved, but I'm not sure how long this will be relevant. As soon as we get pembrolizumab upfront, I think nivolumab is not playing a role in the second line anymore. And for the adenocarcinomas of the G junction and the stomach, I expect nivolumab to be approved at least with a CPS score of 5 and more. The question is about the all-comers, and we also have to question the role of pembrolizumab in G-junction cancer. We know that MSI high tumors, approximately 4% in the metastatic setting, are highly sensitive to immunotherapy, and I would ask the insurance companies to reimburse checkpoints upfront like we have seen in colorectal cancer. And of course, we need more robust biomarkers, tumor mutational burden. We have to test regularly for EBV positivity because they do respond very well on immune checkpoint as well. So, and with this, I thank you very much for your kind attention. Many greetings from snowy Munich. And yeah, I really remember a really good time when I could visit your country. It was a really great experience. And I hope we're going to see each other soon, not only virtually. Thank you very much.
Thank you very much, Dr. Sylvie, for your great presentation. I leave the microphone now for my colleague, Dr. Walid Sulewi. Dr. Walid Sulewi is a consultant medical oncologist at King Fahd Specialist Hospital in Dammam. He will introduce the next speaker. Dr. Walid.
Yeah. Thank you, Dr. Prof. Majdi. Thank you for both Speaker Kanaan and Professor Sylvie for excellent and elegant presentations. It is my pleasure now to introduce Professor Gerd Prager. He is Professor of the Internal Medicine and Medical Oncology at Vienna, and he is the GI chair or head of the GI oncology program, and he is the medical in the Medical University of Vienna, and he is have a lot of publications and peer review articles, and is the one of the ISMO chairs regarding
sorry, can you stop sharing? Dr. Sylvie, can you stop sharing?
Yeah. He will, Professor Prager, he will talk about the recent advances in metastatic pancreatic cancer. Without further ado, please, Professor.
Yeah, thank you very much. It's a big pleasure for me to share with you the recent data on the treatment of metastatic pancreatic cancer. It's a big pleasure and honor for me that I've been invited. I'm happy to be here. I would be even more happy to see you face to face, but hopefully next year. These are my disclosures. So pancreatic cancer is not a conventional disease. We know that in contrast to many other cancers, the success or the improvement in the 5-year survival rate were very low. So, however, there is some progress. So when we have seen a 2% 5-year survival rate in the 70s of the last century, we have been in the last decade about 8% of 5-year survival rate. Recently, however, there was a step forward, so we reached the 10% of 5-year survival rate. In contrast to other solid tumors, it's still very poor. However, there are some progresses towards a better prognosis of our patients. I will try to summarize the most recent data of advantages we have made within the last 12 months. When it comes to metastatic pancreatic cancer, there is a clear indication of starting a treatment with a combination chemotherapy as long as the patients are fit for doing so. So there is always the question, should we start with a triplet combination like FOLFIRINOX, modified FOLFIRINOX, or should we go for a gemcitabine plus nab-paclitaxel combination? There never had been a head-to-head comparison trial in this setting, so I don't have a real answer for you. However, there had been a lot of analysis comparing these two regimens, and what I present here to you is a meta-analysis showing that there is no superiority of one regimen over the other. Even if we look into our daily clinical setting, and these are data from Austrian centers from my home country, where we compared patients treated with FOLFIRINOX or nab-paclitaxel gemcitabine, and we compared the overall survival. On the left-hand side, you can see that there is no significant difference between these two regimens when it comes to the prognosis of our patients. On the right-hand side, it's a propensity score analysis, so a matched analysis when it comes to prognostic factors. And even there, you do not see a superiority of one over the other regimen. So it's more an individual decision, and based on the availability of the drugs in your centers, whether you start with FOLFIRINOX or gemcitabine plus nab-paclitaxel. However, we have also done some research in looking into special subgroups of patients. At least in my country, most of pancreatic cancer patients are elderly patients, so above 70 years of age. So what we have done in this prospective analysis was we were comparing patients treated with nab-paclitaxel plus gemcitabine in the first-line setting of metastatic pancreatic cancer. We compared the outcome when it comes to progression-free survival, left, or prognosis of our patients, so overall survival on the right-hand side. And what we clearly can see in this multi-center analysis, that even patients who are older have the same outcome, the same benefit when they are treated with gemcitabine plus nab-paclitaxel. So same progression-free survival and same prognosis. So age is not the limiting factor for an effective treatment. This publication is accepted and impressed. However, within the last years, there were not many positive phase 3 trials, as you can see here on this timeline. So in the last decade, there was the introduction of FOLFIRINOX, which was superior to gemcitabine as a monotherapy. This was published in the New England Journal of Medicine in the Brodich trial in 2011. 2013, there was the introduction of nab-paclitaxel plus gemcitabine to be superior when it was compared to gemcitabine. That was the so-called MPEC trial. And in the year 2015, the Napoli-1 trial was presented and published, which was a second-line combination of liposomal irinotecan plus 5-FU-leucovorin when compared to 5-FU-leucovorin alone. But this was in a second-line setting of pre-treated gemcitabine based treatment in the metastatic setting. Since then, there were no positive trials with the single exception of olaparib as a maintenance treatment for germline BRCA mutated patients. I will show you in a minute. A lot of other clinical phase 3 trials were negative. Among them, napabucacine, the stem cell inhibitor in combination with a chemo combination, pegylated IL-10 when it was combined with FOLFOX, PEG-PH20 when it was combined with nab-paclitaxel gemcitabine. Unfortunately, all these trials turned to be negative, as well as immunotherapies. So when we look on the most recent clinical phase 3 data, you only see one positive trial, olaparib versus placebo in the maintenance setting of patients with a germline BRCA mutation, pre-treated with cisplatin or oxaliplatin. The other trials, unfortunately, were all negative. So let's put a focus on the most recent positive phase 3 trial. In the phase 3 POLO trial, patients were only included if they had a germline BRCA mutation. All patients were pre-treated with a platinum-based chemotherapy. So most of them had FOLFIRINOX, some had the cisplatin gemcitabine combination. As a prerequisite, the patient needed to have a stabilization of the disease or tumor shrinkage for at least 4 months, so disease control for at least 4 months, before they were included into this trial, randomized with a 3:2 ratio, and treated with either olaparib as a monotreatment or placebo. The primary endpoint was progression-free survival upon this maintenance treatment. As you can clearly see here, olaparib treatment led to a superior progression-free survival. Mature overall survival data, however, did not demonstrate a significant difference in the overall survival of the patients, independently whether they were treated with olaparib or placebo. However, for the ESCO GI meeting, a virtual meeting in January 2021, the final overall survival data will be presented. NCCN guidelines already incorporated patients with a germline BRCA1 or 2 mutations as well as PALB2 mutations to be treated after platinum-based first-line treatment with a continuation of olaparib. Olaparib in this setting is also approved in Europe by the European Medicine Agency. What about immunotherapy? Sylvie Lorentzen clearly demonstrated the benefit of patients treated with an immunotherapy in gastric cancer, as well as the MSI patients, MSI-high patients with colorectal cancer. The question is immunotherapy also an option for patients with pancreatic cancer? It seems to be much more complex for the adenocarcinoma of the pancreas. We have seen data, even combinations of checkpoint inhibitors, and unfortunately, they were all negative. So CTLA-4 plus a PD-1 inhibitor did not show to lead to any effect in pancreatic cancer patients, not even if they treated alone with immunotherapy. And also, as we have seen at the ESMO meeting this year, it did not improve the prognosis when it was combined to gemcitabine nab-paclitaxel. Even if we look on the MSI-high patients, as this is demonstrated here in this Keynote 158 study, pancreatic cancer patients, although limited amount of patients were included, they had not the same response towards pembrolizumab when compared to other solid tumors. The response rate was poor with just 18%, the median PFS just 2%, and the overall survival was in median just 4 months. So this is not something we would expect from MSI-high tumors. So pancreatic cancer also for the MSI-high seems again to be different to other solid tumors. So let's talk about second-line options. We see more and more patients being fit enough to be treated beyond progression of first-line treatment. So when we start with a 5FU-based first line, we can go to a gemcitabine-based second-line treatment and the other way around. Gemcitabine-based first line, you might go in the fit patients with a 5FU-based second-line treatment. And I think very consistently, patients who are not fit enough, so ECOG 3+, we should not treat with chemotherapy anymore. There are, however, some conflicting data when we talk about second-line oxaliplatin-based regimens. We have seen a positive trial, the so-called CONCO-03 trial, where 5FU was combined with oxaliplatin in terms of the off regimen. This led to an improvement of the overall survival and progression-free survival. Both endpoints were statistically significant. However, in another clinical phase 3 trial, the pancreatic trial, the modified FOLFOX regimen was used, and there was a statistically significant inferiority in the overall survival of patients treated with oxaliplatin when compared to 5FU alone. And also the PFS did not differ significantly by the addition of oxaliplatin in the pancreatic trial. So we have controversies in the treatment of patients in the second line when we use oxaliplatin. Positive trial, CONCO-03, negative pancreatic trial. They were quite similar in their design with only minor difference. Different regimens were used. There were more often a dose reduction of oxaliplatin in the FOLFOX trial, and there was this minor inclusion criteria difference. The CONCO-03, the patients had to be progressed during first-line treatment, and in the pancreatic trial, within 4 weeks after the first-line treatment. However, for the second line in this setting, we have seen recent data of a liposomal irinotecan. So this is irinotecan embedded in a liposome. We know from preclinical data as well as from clinical analysis that the irinotecan, when it's embedded in the liposome, has a higher bioavailability in the tumor, a better half-life time. And this led to positive results in the clinical phase 3 trial Napoli 1, where the addition of liposomal irinotecan to 5-FU-leucovorin in gemcitabine pre-treated patients led to an improvement in the prognosis from 4 to 6 months with a hazard ratio of 0.74. The progression-free survival in numbers almost doubled up with a hazard ratio of 0.56, which was also statistically significant. But 10% were still alive after 20 months of the second-line trial. So this was the published trial, and you might have been aware of this data. However, there also had been subgroups analysis. Again, the elderly patients, as you can see on the left-hand side of the slide, had the same benefit when compared to the younger patients. So cutoff rate 65 years, 70 years, 75 years, there was the same benefit. If you look on the right-hand side, it was also interesting for our Asian patients that in the Napoli 1 trial, they also had the same benefit from liposomal irinotecan when combined to 5-FU, when compared to 5-FU alone, with an even trend to be even better with a hazard ratio of 0.51. So we also did our same analysis in the real-world setting. In our patients group, the median overall survival was even a trend to be better than into the clinical phase 3 trial, with a median OS of 7 months. And also, if there was a dose reduction, the benefit was not diminished. Quite similar data from our colleagues from Italy, median OS of 7 months also observed in their patient population. When it comes to the comparison, when you should use the liposomal irinotecan in the second line or later on in third, fourth line setting, there's a clear signal that you should use liposomal irinotecan as early as possible to have an improved outcome. We did publish this last year, and this year quite similar observations were published from our colleagues from the United States that an early onset of treatment of liposomal irinotecan did lead to a better prognosis of our patients. We also did some analysis showing whether liposomal irinotecan, when compared with oxaliplatin in a propensity score-like analysis, had an improved outcome. So in the second line, liposomal irinotecan was superior towards an oxaliplatin-based treatment. All patients were pre-treated with gemcitabine in first line. So finally, this leads me to this algorithm. Although this slide was a courtesy from Teresa Macarola from Barcelona, but I think we very much agree. So in blue color, this is supported by randomized clinical data. First line, you have the choice of nab-paclitaxel gemcitabine or what we use in modified FOLFIRINOX. And then in second line, the gemcitabine pre-treated can go to liposomal irinotecan or the off regimen. And we even have third line treatment settings available, something which is new we didn't have a few years ago. So when we look to our colleagues from the United States, what they put into their NCCN guidelines, they also do a separation from gemcitabine pre-treated versus fluoropyrimidine pre-treated patients. And what you can clearly appreciate is patients who were pre-treated with fluoropyrimidine, you should also switch to gemcitabine. What NCCN is also suggesting is that you can do in a second line a combination of gemcitabine plus nab-paclitaxel. However, you have to be aware that in the second line setting, there has been no randomized prospective data whether the addition of nab-paclitaxel is indeed superior to a gemcitabine monotherapy in the second line setting. NCCN is also suggesting liposomal and irinotecan for 5-FU pre-treated patients if no irinotecan was given earlier. So let's talk about second line nab-paclitaxel gemcitabine, because there is very often a question whether you can use it after FOLFIRINOX regimen. There are no, as I mentioned, randomized prospective data. The biggest data set is from an analysis, prospective analysis from a French trial. This AGIO prospective multi-center cohort, which is not a randomized cohort, however, does suggest that nab-paclitaxel plus gemcitabine in the second-line setting after FOLFIRINOX failure might have a promising outcome. Limited patients numbers, however, quite good data when it comes to PFS and overall survival. So the question we were asking our center, are these advantages leading to an improved prognosis of our patients? So we were doing an analysis of 300 patients of our center, and we're subgrouping them for the years of diagnosis, either 2011 to 2013 or 2014 to 2017, where we had in the latter patient group more treatment options available. What you can clearly see is patients diagnosed later, we are now using more nab-paclitaxel gemcitabine before. About 15 to 20% of patients we start with modified FOLFIRINOX. 2/3 of our patients start with the second-line treatment, and since the introduction of liposomal irinotecan, we had about 50% already in these years treated with liposomal irinotecan. The question is not only what do we use for treatment, but what is the benefit of novel treatment options? And this is demonstrated here. If we compare the overall survival of our patients in the slide A, you can see the overall survival from start of first-line treatment. There was a significant improvement in the prognosis with a median OS of almost 12 months, which was with a delta of 3 months better than in the years before. Most likely, the overall survival benefit was coming from the second-line treatment, as you can see here in the figure B, where we had still a hazard ratio of 0.77 due to novel second-line treatment options. So in the year 2020, we have first-line treatment options, we have second-line treatment options, and we have third-line treatment options. I'm aware that not every patient is indeed fit enough and will see all lines of treatment, but we have more treatment options available, and it's possible for a sequential treatment, sparing unnecessary toxicity to our patients in the first-line setting. So let me sum up. We have seen some small steps in the improvement in the treatment of metastatic pancreatic cancer. So we are going now to a 5 years OS of 10% right now. More patients are fit for a continuum of care strategy. I think, especially in the last 5 years, the introduction of second-line treatment options was the key for an improvement in the prognosis of our patients. Our preferable option after gemcitabine first-line treatment is liposomal irinotecan 5-FU, and this is very consistent with the treatment recommendation of international guidelines. However, there's still an unmet need for novel treatment strategies in a metastatic setting of pancreatic cancer. So this is a picture of my home city, Vienna, and thank you very much for your attention.
Thank you, Prof. Berger, for the excellent and elegant presentations and update about metastatic pancreatic cancer. We'll keep that. We have a lot of questions. We keep to the end of this session. Thank you. It is my pleasure to introduce the next speaker. Is well-known Dr. Ghassan Abu Alfa. He is the attending physician and is a professor of the internal medicine and medical oncology at Memorial Sloan Kettering Cancer Center and is in the medical oncology at Cornell University. He has a lot of publications and peer review, and he is specialized in the GI cancer, mainly in the HCC and biliary cancer, and he is chair of the NCI, and he's the chair of the medical scientific board of the Cholangiocarcinoma Foundations, and also he's the National Medical Advisory Committee of the American Liver Foundations. He will talk today about 2 presentations. The first presentation about immunotherapy versus TKI for HCC. The another presentations, he will talk about how to treat patients with cholangiocarcinoma. Without further ado, please, Dr. Ghassan.
Thanks so much, Dr. Selvi. Thank you, Walid. I'm not permitted to open my video and, oh, here we go. Perfect. Thank you.
Okay.
Wonderful. Thanks. Good morning, everybody. So I'll just share my screen and then we'll go ahead and start.
Yes, please.
So again, great morning to everybody, and thanks again for the invitation. Congratulations, Dr. Al-Hamid, for leading this effort. And Dr. Selvi, thanks so much for your nice introduction. So nice that I see the panel led that I'm on by my dear friends, Dr. Majdi, Dr. Amani, and of course, my very dear friend, Dr. Ashwaq. As you kindly requested, we'll talk about the IOs and TKIs and hepatocellular carcinoma, and of course, how to select. These are my contacts, and if you would like, you can take a picture or copy, or of course, the moderators and the conference has them as well, and I'm more than happy to connect at any time. So to start with the perspective of the checkpoint inhibitors, as I was asked to talk about, we all remember the story of Checkmate 459 that wanted to compare nivolumab to sorafenib. The perspective at that time was that understandably nivolumab, it's a new anti-PD-1, why not? And actually everybody was expecting the study to be a positive study. Well, sadly, it was not. And as you can see over here, there could be some red possible trend, but it did not really meet any statistical benefit, with the hazard ratio of 0.35. And even on an update, still the hazard ratio is 0.85. As we all know, this will be called a negative study. Could nivolumab apply to very specific, well-selected patients? Maybe, but this is yet to be further analyzed at this point in time. With this said, we moved on to a more robust work that start addressing the combination of therapies. And as we all know, the combination of atezolizumab plus bevacizumab was compared to sorafenib, and it showed a very clear improvement in survival. As you can see over here, it's not yet even met at median, but we expect it to be somewhere around like 20 months or so. Based on the fact that there's only 3 patients left on the study by that time, versus sorafenib with 13.2 months. This definitely changed quite a bit of the field and defined atezolizumab plus bevacizumab as a new standard of care therapy. However, an important point came into play, which admittedly all of us, not necessarily we knew about much, but I take you back in time to a study by Dr. Enrico and colleagues in the clinical cancer research that looked into the potential for developing anti-drug antibodies for all checkpoint inhibitors. In other words, in simple terms, you give a patient a certain checkpoint inhibitor, they might develop antibodies against that checkpoint inhibitor, make it as if it's not there for them to really benefit from, and as such as if they didn't get it. Interestingly, as we can see to the extreme right, some of the checkpoint inhibitors, this is really very minimal potential. As you can see, pembrolizumab and durvalumab, it's 1 to 2%. But on the other hand, on the extreme left, you can see that atezolizumab, the chance for anti-drug antibody is close to 50%. In other words, of every 2 patients you give atezolizumab to, one of them as if they did not get atezolizumab. This data, by the way, applies to all cancers, not necessarily for HCC only. But interestingly, if you were to look in the package insert of the atezolizumab, you'll see the following add-on information from the FDA. It shows very clearly what I showed you at data for the atezolizumab plus bevacizumab versus sorafenib. The hazard ratio is 0.58. Now, if we were to split the population into patients who did not develop anti-drug antibody negative, in other words, the hazard ratio improved to 0.39. Super impressive. But interestingly, if you recall about a potential, we don't know the number yet, but a potential up to 50% patient if they were to develop anti-drug antibody positive patients, in other words, the hazard ratio declined all the way to 0.93. In other words, the atezolizumab plus bevacizumab remains as equal as it is to sorafenib. The question, who are those patients? Can we test for those patients? Unfortunately, we can't do either. So in other words, patients, they will be randomly kind of, getting the drug, and they have at least based on what we know, it could be hopefully better, but at least that we know 50-50 chance that they will not really benefit from the atezolizumab plus bevacizumab. And interestingly, as such, it make it look like a sorafenib, which I'll take you back in time to talk a little bit about the TKIs. This is a sharp trial that compared sorafenib to placebo. A major improvement in survival, 10.7 months. In those days, we have to remember there was nothing else. We have to compare it in that perspective. And then where there's been a long period of time without really any major breakthroughs that we all contributed to until the time of lenvatinib versus sorafenib. Lenvatinib versus sorafenib is rather pretty intriguing study because, as we can see here, the Kaplan-Meier shows a clear kind of connection between the two arms, lenvatinib and sorafenib, 13.6 months for lenvatinib, 12.3 for sorafenib, but still this is called a positive study. The hazard rate is 0.92, same as what just discussing for the ADA positive patients. But interestingly here, the question was not if lenvatinib is better than sorafenib. The question was, is lenvatinib as good as sorafenib? Why did they do it that way? Well, not really sure, but it could be that there was a certain perspective that, after all, we know how much TKIs can do. It's like, as it being a racetrack, this is how long is a racetrack, 13 to 12 months, and that's it. You can't really push it further. But can, within that racetrack of 12 to 13 months, the lenvatinib can go faster? Interestingly, it seems it does. We can see over here that in the progression-free survival, the lenvatinib 7.4 months, almost 2.7 times higher than sorafenib 3.7 months. Now, to go back to the combination, because you already can see where I'm going with this, is to really look more about the IO plus TKI rather than O versus TKI. And one of them is a combination of lenvatinib that we just spoke about, plus pembrolizumab, and it shows very clearly a robust response rate, including complete responses. And if anything, why lenvatinib plus pembrolizumab could have worked that way? It seems that probably, yes, there is a certain synergy that does occur between the two. This is not on lenvatinib. There's another anti-FGFR, erdafitinib. But if it were to be combined with anti-PD-1, clearly we can see a major decline in Ki67 and an increase in CD3, which means killing cells and same time enhancement of immune response, which probably what could have explained to that improvement of response with the lenvatinib plus pembrolizumab, which translated on that limited phase 1/2 study with a survival of 22 months. Understandably, we're awaiting the LEAP-002 study that will tell us if truly lenvatinib plus pembrolizumab will pan out. Another story which is very important about the checkpoint inhibitors and of course about the immunotherapy altogether is one of the anti-CTLA-4. To rather introduce this first, anti-CTLA-4 is rather a very intriguing component of the immune response that we all get in our body. CD28, which happening to be in the lymph node, will talk to CD8 and 86 and will enhance them to pass on a certain message to the tumor cell where the PD-1 and PD-L1 are there. Interestingly, CTLA-4 kind of, convince CD8 and 86 to hang out with it rather than with CD28. And if anything, put them to sleep. They cannot really do their job anymore. And that's why anti-CTLA-4 come into play and will take away CTLA-4, permitting CD28 to exert its influence on CD80 and 86. And as such, anti-CTLA-4 clearly are a very critical component which happen to have it in the lymph node level in regard to enhancing the activity of the anti-PD-1, anti-PD-L1. By the way, I just described in as simple terms as I can what the Nobel Prize from last year that was received in regard to immunotherapy. That's exactly what the story was. And as such, using that story, we presented data on durvalumab plus tremelimumab, a combination that, interestingly, one dose only of the tremelimumab at 300 milligram plus durvalumab improved survival up to 19 months. Understandably, we are to await for further details on that combination that will come up from the Himalaya study that's looking into the T300 plus D, one dose of the tremelimumab at 300 plus durvalumab versus sorafenib. Interestingly, though, to go back to the checkpoint inhibitors one more time, the nivolumab, despite that I mentioned that it was negative in the 459 study, it still got approval in the FDA in the US at least, based on that data. And if anything, this limited phase 2 data showed the duration of response. This is really what everybody was so keen on to see, as we can see here, that the duration of response could have continued up to 24 months or so. The same applied, by the way, to pembrolizumab, as you can see over here, again, with prolonged duration of response. Despite that, pembrolizumab, as single agent, was compared to placebo and still had a negative study. Hazard ratio, as you can see here, 0.781. So I'll go back one more time to the TKIs. In second line, we have regorafenib that was compared to placebo, interestingly, positive, 10.6 months. There was a requirement here to have prior sorafenib before regorafenib. Another one is cabozantinib that we probably published in the New England 2 years ago, and it shows clearly an improved survival versus placebo. And also ramucirumab that was again showing a positive outcome compared to placebo, maybe a little bit less impactful, limited to 8.5 months, with alpha-fetoprotein at baseline more than 400 as a requirement. And you can say that maybe those patients are sick or more sick to begin with, but nonetheless, it's appropriate. If anything, I wrote the discussion in that same paper when Dr. Zhu presented it in the last oncology. And I said that alpha-fetoprotein is not yet defined as the sole tumor marker for HCC. And finally, we'll talk about the combination, again, one more time, of anti-CTLA-4 plus anti-PD-L1. Here is nivolumab, anti-PD-1 plus ipilimumab, showed a great improvement in surface response, as we can see over here. And at ASCO this year, there was a discussion that was given by Dr. Tim Meyer from London. And if anything, there was a concern, though, about the adverse events from the nivolumab, ipilimumab, which was given on a repetitive basis. And he compared it, not really an appropriate comparison because there are two different studies, but nonetheless showed that T300 plus D, which I showed you about tremelimumab plus durvalumab, had much less grade 3 and 4 events in comparison to the nivo-ipi. So if anything, what are we, or where do we stand nowadays? If we're to think everything is available, we have atezolizumab in first line, sorafenib in first line, lenvatinib. And second line, we have rigo, cabozantinib, ramucirumab, pembro, nivolumab, ipi-nivo. And then third line, cabozantinib again. Interestingly, though, could it be that we have to start thinking a little bit in a different approach where we can think of what we called line -1, atezolizumab, lenvatinib, pembro, durva-trami, and still we're not going to ignore the sorafenib, lenvatinib. We keep them as first line and move on everything by one step down, as we can see over here. I know I presented a lot of work, and I please urge you to take a picture, and you can take that QR code and register for this very critical meeting about that further discussion that will be happening tonight. It will be a little bit late in Saudi Arabia. It will be very early morning, but it's the weekend. Hopefully, you'll still join us. This is the Apple meeting. We're greatly honored and proud to be able, for the first time ever, host the Asia Pacific Liver Cancer Expert Association meeting, the Apple, from the United States of America as a Pacific country. And we are today joined by colleagues from literally all over the world. As is this morning, before I came to this meeting, we found that we have registrants literally from every continent on Earth. And it is a single topic conference on the tumor immune microenvironment for hepatocellular carcinoma. We look very much forward to see you. This is done in collaboration between Sloan Kettering and University of Hawaii Cancer Center in Honolulu. Thank you very much for listening. Thank you.
Thank you, Dr. Ghassan, for elegant presentations. If you can proceed with the second presentations, how to treat cholangiocarcinoma today, please, Dr. Ghassan.
Thank you so much, Dr. Sawi. By all means, I'll do so. So I'll just switch my slides to the second lecture. And this time we're going to talk, as we just heard from Dr. Sawi, we're going to talk about cholangiocarcinoma. And I was asked to discuss how to treat cholangiocarcinoma today. Again, one more time, these are my contacts in case you missed it on the first lecture. And I'm happy to, again, give it for a few seconds to let you take a picture if you need it. And we'll talk about the following three or four rather items that are really becoming hot topics in regard to cholangiocarcinoma. Number one is cytotoxic therapy. We'll talk about IDH and FGFR targeting, and we'll talk also about immunotherapy. In regard to cytotoxic therapy, I think we all know it, and we use it every day in our presentation, in our practice, based on the ABC02 study, an elegant study that was done in the UK by Dr. Juan Valle and colleague from Manchester, that compared gemcitabine plus cisplatin to gemcitabine single agent and showed an improvement in survival, 11.7 months versus 8.1, that led to our understanding and acceptance of gemcitabine cisplatin as a standard of care for the biliary cancers. The progression-free survival was also high. It kind of brings a little bit of a question about that maybe the non-repetitive imaging in the study led to the progression-free survival to be close to the OS, understandably so. And interestingly, to carry on further on that, a current study reported phase 2 trial of gemcitabine cisplatin added nab-paclitaxel, and as we can see here, showed a clear improvement in response, PFS 11.8 months, and suggested OS of 18.8 months. Always I like when I talk about phase 2 studies, I'll talk suggested OS because it was not yet geared for OS. Nonetheless, as I mentioned, this is currently ongoing a large clinical trial comparison to gemcitabine cisplatin, which is happening here in the US and Canada. And we'll have to wait for the results of that study before we claim that the triplet of gemcitabine cisplatin nab-paclitaxel is a standard of care. So please, I urge you not to use it until we have the data from this WOC study. Now, in second line, and this is, by the way, the study that I'm just referring to as it's happening as we speak. Now, at the same time, there has been discussion already about second-line therapy, specifically chemotherapy for biliary cancers. This is a nice work that was presented last year at ASCO by the group from Manchester again. Dr. Lamarca presented the FOLFOX versus placebo or best supportive care in patients in second-line therapy and showed again an improvement in outcome. I'm eager to wait for the ultimate reported manuscript, and especially the perspective of, because we know in the UK, they treated patients with gemcitabine cisplatin only for a limited period of time, of about close to 6 months. And after that, patient to claim that they continued on FOLFOX, could it be a continuation of a platinum compound rather than a progression? That's really yet to be seen, because they smartly did present the data in regard to prior cisplatin resistant, cisplatin refractory, and cisplatin responsive. So we just have to wait for more details on that. Nonetheless, it's an option which was nicely studied as well. With this kind of like still relatively limited perspective on chemotherapy, I would say our focus changed solely to the targeted therapies, because we have discovered, and this is beautiful work that we presented from Memorial a couple of times, and now it's published in CCR. We have shown that the specific genetic alterations that can occur in regard to cholangiocarcinoma can have certain mutual exclusivity. In other words, if a patient has an IDH1 mutation, they are not necessarily they will have another alteration. Specifically, the one I'm referring to is FGFR2 fusion, because we are keen on seeing targeting for both of them because we have therapies that are applicable for both of them. That mutual exclusivity will urge us, please, and I really urge you to make sure that any patient with cholangiocarcinoma, make sure that we do test the next generation sequencing even before we touch them, before we do any therapy. And of course, this can be done on different platforms. Many of them are available to you, and including Foundation, Caris, and many others. And I'll add here the impact that is available in Sloan Kettering, which I know several patients from Saudi Arabia have already benefited from. IDH1 is rather a very intriguing point, because if we can see over here that in our kind of messaging that occur in the cytoplasm, the mutation of IDH1 will lead to a certain increase in 2-hydroxyglutarate. We can see it in yellow right at the center, and this will actually enhance further the production of uncontrolled cells, i.e. cancer cells. So by the way, of course, blocking the IDH1 will make a lot of sense if it's mutated. So as such, we did this clinical trial that we proudly already published in Lancet Oncology, and we presented last year at the ESMO meeting at the presidential session in Barcelona, that we compared patients with ivosidenib to placebo. The study was positive. It allowed actually a crossover from the placebo to the ivosidenib, and we did this because a lot of the patient advocacy really felt like we need to give the opportunity for every patient to be tested on. So pretty much you can say that everybody could have gotten the ivosidenib probably early or a little bit later. Nonetheless, as you can see over here, there was an improvement in regard to the progression-free survival, which was the primary endpoint. And clearly the split start becoming more apparent after 6 and 12 months, because as we can see, there were no patients left on the placebo arm by that time. And the survival also did improve. As you can see here, maybe they were comparable between the ivosidenib and placebo, and understandably it's going to be very hard to understand survival because of the crossover. But interestingly, when we did what's something called rank preserving structural failure time, it's a technique in statistics. I kind of learned it along the way. It's done quite a bit in prostate cancer. And if anything, it will help you calculate what if patients did not cross from placebo to ivosidenib. Then interestingly, the survival improved markedly, where now we're talking about a 10.8 month for the ivosidenib versus only 6 months for the placebo. The drug is not approved yet, but it's available in the market for other indication in the hematologic world, but hopefully we'll look at that indication approval soon. FGFR is another intriguing story, because if anything, FGFR fusion can occur in cholangiocarcinoma in about 5 to 10% of the patients. At best, probably you can say 15, but probably the average about 5 to 10% of the patient. We proudly, many of us were involved in that study of the BGJ398 that later on became called infigratinib. And we can see a very robust response and duration of response that actually it triggered a lot of intrigue in regard to the anti-FGFR2, among which pemigatinib, which we proudly again reported last year at ESMO. And again, we led the effort from Memorial that was published in Lancet Oncology that looked into pemigatinib and looked specifically into patients with FGFR fusion, other FGFR alterations, or no alterations. And survival and response were great. We can see here response rate up to 35%, which is quite robust with even some CRs. And the survival, especially for cohort A with the fusion, is 21.1 months. That data led to the approval of pemigatinib in second-line therapy for patients with FGFR alterations by the FDA. Those two drugs, by the way, infigratinib and pemigatinib, are still being evaluated in phase 3 clinical trial and to look into first-line therapy against gemcitabine cisplatin as a first-line treatment. We proudly, and this is a collaborative work and teamwork that we all should do, we felt this is a rare population of a rare disease with a rare genetic alteration. So we, hand in hand, collaboratively with our colleagues at MD Anderson, led the effort, and we're co-leading it from Sloan Kettering and MD Anderson for the infigratinib, for the idea that let's get some study with high accrual and try to get some answer for our patients wherever they are. Nonetheless, there is another story which quite intriguing. If you give an anti-FGFR for a patient and they progress, what happens? Nice work that was done by Dr. Goyal in MGH in Boston that actually looked in biopsies, even sometimes at autopsies, looking again at the tumor and analyzing what mutations they have. And as we can see over here, the patients that had a specific gatekeeper mutation where you can attack it, if it is to really change to another gatekeeper, patients might not benefit anymore from the therapy. And we can see here the FGFR2 V564F as an important gatekeeper. This is something to keep in mind, that we might ultimately see a model where we have to jump on from one to the other FGFR2 based on what the mutation that is at play. And immunotherapy, no doubt, has been already looked at. This is beautiful work that was done by our colleague, Dr. Kim from Florida, and published in JAMA Oncology, looking at nivolumab. And if anything, response rate impressive, 22%. PFS limited, 3.5 months, and 14.2 overall survival, again, within the limited phase 2 study, hard to predict. But nonetheless, it appears to be that maybe it benefited in patients who are enriched for PD-L1. Another story, of course, can be from the nice work of MSI-High. And this is, as we can see, MSI-High, yes, can occur in cholangiocarcinoma, but it's not that common, probably about, at best, 5%. So I would not, but of course, look for it, but at the same time, I would not really get too excited as if it's going to be the answer. And if anything, again, combination probably might be best. This year at ASCO, there were 2 studies, the one from Dr. Sahai from Michigan, and the other one of Dr. Do-Young from Korea, that looked into a combination of Gemcis plus Nivo and Nivo-Ipi, and another one Gemcis plus Durva plus Gemcis Durva Trami. And you see how the nice subject of the anti-CTLA-4 is coming to play again. And as we can see over here, we had clearly an improvement in outcome with great PFS and great response rate. Phase 3 trial with the combination, including chemotherapy plus immunotherapy for biliary cancer, definitely is awaiting further studies. And again, these are already ongoing. As you can see here, there's an endless number of clinical trials. And by all means, at any time, please, it's very important to accrue to those trials. So I would not jump into conclusions and give checkpoint inhibitors without clinical trials, and wait until the results coming on those. So again, I thank you again for your attention. And I summarize that gemcitabine cisplatin are no doubt still a standard of care. We have to wait until we see if nab-paclitaxel will add on, and this is a clinical trial component. On the other hand, MSI, yes, for sure, checkpoint inhibitors. On the other hand, for the combination therapies, we have to wait until further data comes out. And again, please join us tonight and tomorrow night for the hepatocellular carcinoma of the apple of the tumor immune microenvironment. Thank you very much for listening, and thanks for the invitation.
Thank you, Dr. Ghassan. And now we open the questions. Dr. Prof. Majdi Gandil, please, he can start with the first questions from the audience.
Question. I want just to mention that we have now reached to 1,818 attendees. When we exceeded 1,000 attendees, it has been changed to YouTube. We'll start the pull-out question to start your to see whether it's working or not. Did you attend ESMO or WCGI or ASCO virtual this year? Yes or no?
Dr. Qandil, can you invite Sylvie and Gerald as well to be in the call?
Yes.
Gerald and Sylvie, can you please join us again?
Yes, I'm here.
Okay, perfect.
I'm too. Me too.
Okay, perfect.
You're welcome. Okay. The polls. Can you stop sharing?
for results.
So 34% have attended the all the meetings. 66% did not. Okay, go for next question, please. Next, please.
Okay, so
If you have a 52-year-old gentleman with ECOG performance 0, diagnosed as mid or lower rectal cancer, T4N1M0, high risk, would you give the Rapido protocol or the modified FOLFIRINOX protocol upfront, or conventional chemoradiation protocol? Dr. Kanaan, you are with us?
Yes, certainly. Thank you, Dr. Majdi. So do you want me to wait until people vote, or do you want me to give my insights before?
Give after the result. Yes, sure. Can we have the result, please? So Rapido 48%, modified FOLFIRINOX Prodige 22%, and the conventional 31%. Can you comment, Dr. Kanaan?
Of course. So I'm glad the not a lot of people chose the conventional chemoradiation. So long course chemoradiation followed by TME followed by adjuvant chemotherapy. So I think if we actually think about Rapido or Prodigy, I think both trials give us an insight that TNT actually does affect tumor regression, and chances of PCR are significantly higher with TNT. So for bulky tumors, and good patients, of course, and patients who have good follow-up and are willing to come to hospital to receive chemotherapy followed by chemoradiotherapy, we always prefer the approach of TNT. Now, when we think about the OPERA trial as well, it did tell us that if we actually start with long course chemoradiation followed by chemotherapy, which is consolidation chemotherapy, that these patients actually had better tumor regression. So perhaps consolidation chemotherapy after chemoradiotherapy is the way to go for bulky tumors.
For me, the Rapido protocol in the corona pandemic that presents maybe a very useful protocols, and I think many are using. The next question, Keynote 177 pembrolizumab in MSI metastatic colorectal cancer, is practice changing? Yes, no, I prefer to wait overall survival data. Can we have the result?
Yes.
Yes. Professor Sylvie, please comment.
Yes, thank you. Interesting question. As I think we will soon get the approval of the FDA for first-line pembrolizumab. I think it is kind of changing, and so I agree with the majority of the participants voted for yes. Although I still think the no participants might have thought of rather giving the doublet Nivo-Ipi, which is not approved, and which have only looked at 45 patients. But I think this is also a way to go. So I think immunotherapy in general is the way to go in first-line MSI high tumors.
Next, please. Dr. Walid.
Yes.
Checkmate. Okay. Walid, please.
Yes. Checkmate 577 nivolumab as adjuvant therapy post-resection in the stage 2, stage 3 esophageal cancer. GE junction is changing landscape.
Agree, disagree?
Agree, disagree. I prefer to wait overall survival data in adjuvant setting. Please. 74% disagree, and 10% disagree, and 16 prefer to wait. Prof. Sylvie.
Yes, although I like to comment, although I did not address this trial because my talk was on metastatic disease, so that's why I skipped the 577. But I can quickly comment. The 577 randomized nivolumab versus placebo in previously radiochemotherapy and then resected locally advanced squamous cell and adenocarcinomas. And I think the results are very promising for the squamous cell carcinoma, although they only were about 30% of the total population. I'm not sure about the adenocarcinomas because at least we in Germany, we rather prefer giving perioperative chemotherapy with FLOT, and we still don't know if what approach is the better, the perioperative FLOT regimen or the neoadjuvant radiochemotherapy. There are several trials looking at a head-to-head comparison for these two strategies. But I think for squamous cell carcinomas who do not have an arterial resection and a PCR, because this was the main inclusion criteria, I think for them it's practice changing, and we ask for reimbursement in squamous cell carcinoma with residual disease for nivolumab for 1 year.
Okay.
Dr. Walid.
Checkmate 649 Nivo plus radiation therapy in metastatic gastroesophageal and GE junction is positive study. Overall survival and progression-free survival. Agree, disagree, very selective patients. Please. Yeah, 65% agree and 5% disagree, 30% very selective patient. Prof. Sylvie?
Yeah, I think I would have skipped the very in the selected patients because I think it will be a new treatment approach in selected patients depending on their CPS score. I really doubt that it will be the new treatment standard for all patients independent of CPS score. But I think in selected patients with a defined CPS score, I think it's going to be the new treatment approach.
Okay. Next, please.
Sure. I think this was.
I think we already answered this question.
Yeah, I guess so. Okay, landscape.
Yeah. For BCLC, PHC in the hepatocellular carcinoma is not a one size fits all. KIDO score needs to be implemented. Agree, disagree, I'm not aware about it. Please. Uh, 67% is agree and 8% disagree and 26% I'm not aware about it. Prof. Ghassan.
That's an excellent question. I'm so happy you bring it up.
Yeah.
And I totally concur with the 67% of the colleagues who agreed. Just to explain to everybody, especially the 26% that are not aware of it, and I can totally understand why you're not aware of it, because it did not really spread as information to all over the world. It's still mainly kind of in Japan. And one thing that our colleagues who are in the transplant service might understand that better. There's something called the up to 7 criteria. The up to 7 criteria is how we decide on transplant. You count how many lesions there is in the liver. Let's take an example, 4, and you count what's the largest lesion, let's say 4 centimeter. So 4 plus 4 equal 8. This is more than up to 7 criteria. Dr. Kudo, what he have found out that actually if a patient with locally advanced disease, i.e. within the BCLC-B, but with less than or within the up to 7 criteria, fares totally better and way better than patients who are beyond the up to 7 criteria. So he suggested to split the BCLC-B into B1 and B2. And that's why the splitting that you are suggesting, I totally concur with the colleagues who answered yes. And hopefully we'll see this more implemented in the way we manage patients wherever we are.
Thank you.
Question, please.
The landscape of HCC treatment is changing after the IMBRAVE in 150 study as immunotherapy upfront. Agree, disagree, please. $85 agree and 15% disagree. Prof. Ghassan.
I understand totally why 85% are saying yes, is practice changing. And definitely we saw all of that with the paper published in the New England and of course the drug being approved. But I can totally give credit and I concur with the 15% who said no, because I would say this is still in action. As I presented, the issue of the anti-drug antibody is still a serious matter. We need to really get to the bottom of it, because the idea that we give the patients the drug and it doesn't really affect them, as Dr. Majdi just mentioned, especially in the world of COVID nowadays, you have to scope patients, you have to give them therapy. At the same time, ultimately, you know that at least 50% of them, and hopefully less than that, might not benefit from the atezolizumab, and there will be benefit as much from the sorafenib. So why really we need to get patients through this? And in addition to this, the other important component, we're still analyzing data of other important combinations, like I mentioned, pembro, lenvatinib, durva-trami, and many others. And as such, I would not say this is the ultimate answer to the first-line therapy. It's a good answer with its certain limitations, but we just have to wait for more. So it's not really the critical practice changing yet.
Okay.
Thank you. End of polling.
Now we'll go for the questions. We have many questions. We'll start till the time comes for the satellite symposium. First question, for Dr. Kanaan, how do we stratify your patients to select the Rapido protocol versus the FOLFIRINOX neoadjuvant? Which of them you choose and how can you select?
Thank you, Prof. Majdi. So I don't think there's a straight answer to this question, Prof. Majdi. I think giving TNT in general, so whether Rapido or giving modified FOLFIRINOX upfront, with the goal of shrinking tumors, improving metastases-free survival, and specifically selecting patients with larger tumor burden is the way to go. So I think those patients with higher tumor burden, so higher T3, T4, higher end stage are the ones that benefit greatly from TNT. Now, whether this is Rapido or FOLFIRINOX, I do not think that there's a huge difference. Now, going back to the OPRA trial, which showed that consolidation chemotherapy following CRT or chemoradiotherapy gives better tumor shrinkage, gives better PCR rates. I think this is the way to go in patients with heavy tumor burden upfront.
For Professor Sylvie, RAS mutant MSI high did not benefit from pembro. How you treat them?
It's a really difficult question and a really good question, because we are dealing with a subgroup analysis. Only 22% were RAS mutated, but if you look at the subgroup analysis, they really did not benefit. So the question is, maybe just start with chemotherapy and then add the immunotherapy, or go for a nivo-ipi, because we know that it might be a stronger regimen to give the combination. But it's a really difficult question, and it's, of course, it's a small subgroup analysis, but I would not feel well to start only with pembrolizumab, specifically in patients who might become candidates for secondary resection, because I would fear that they belong to the early progressors with the 30% with the crossing of the curves. So yeah, I would rather go for chemotherapy and then might add immunotherapy, although this is not a label.
Yes, because it's not absolute, and maybe I have one patient who failed several RAS mutant, several chemotherapeutic agents, and then had complete remission on pembrolizumab. So this is not absolute, but the patient will not be comfortable to start, as you said, with the immunotherapy. The second question: how do we stratify your patient to select intensive? Sorry. How do you stratify patient to select intense? How, if we start neoadjuvant chemotherapy FLOT for GEG resectable patients, what adjuvant therapy you recommend?
Well, we usually, if we start with a perioperative approach and we start with FLOT, then we continue with FLOT as it was done in the FLOT4 trial, independent of response and regression grade. It's how it is recommended by the guidelines. However, if the patient does not respond clinically and also not in terms of CT scans and regression grade, and he had high toxicity rate and end up T3 and 2, then we might reduce to FOLFOX or even go into follow-up, because then we might only cause side effects and harm him instead of prolonging his survival.
Yeah,
that's an individual approach. We do not have any data for this, but we have to keep in mind that only 50% of patients are candidates for adjuvant treatment, because all the others are just not in the best condition after resection.
Thank you. For Prof. Prager, there is a question regarding the liposomal irinotecan after failure of FOLFIRINOX.
This is for Gerald.
Yeah, this is for me. Yeah. So after failure of FOLFIRINOX, we would switch to a gemcitabine-based second-line treatment. So I have tried to show you the limited evidence to combine this with nab-paclitaxel, but it seems to add a benefit. And this is also reflected by guidelines that if the patient is fit for a second-line treatment for chemo combination after FOLFIRINOX or modified FOLFIRINOX, we would combine gemcitabine plus nab-paclitaxel. But you have to be aware that in some countries, this second-line addition might be off-label. But it's an effective treatment also in second line. The data are just more limited than in the first line setting. If it's not available in your country, then we would do gemcitabine alone.
Okay, I'm just, I have to elaborate regarding patient. Are you clinical practice to do PRCA testing for pancreatic cancer as a daily practice?
Yeah, we do testing for every patient. We do testing a molecular profile for somatic mutation as well as the germline mutation for BRCA, and we do the blood testing. But this is not in every center, probably in Austria, but in the academic center is standard, yes.
Yeah, thank you for, I need to ask Prof. Ghassan regarding the patient who is failure of immunotherapy, non-immunotherapy response for cholangio or SCC. The question is from the, in the chat, he said, how to treat those patients? I think you are mentioned, but just elaborate regarding these questions, please.
I think, sorry, Ghassan, the question, because if you have HCC and the cholangiocarcinoma, which is cholangiocarcinoma non-immunoresponsive, how you treat this patient? As a combination in one patient, you have HCC and it's small category.
Thank you, Dr. Mirvat. And if anything, the potential for a combination of cholangiocarcinoma and HCC can occur in up to 15% of the patient. And that's why I urge everybody, please, if there's a concern about HCC, make sure you get the biopsy, because this is really the patient you don't want to miss. You don't want to miss. And if anything, the treatment probably that will be most critical is the cholangiocarcinoma 1, and you add to it whatever you can. One of the combinations that we have published on is gemcis plus sorafenib. And in regard to the immunotherapy plus the chemotherapy, we don't really have any data yet. So I would say within the context of a clinical trial, yes, but out of a clinical trial, I'll stick to whatever is published in data, which is TKI plus chemotherapy.
Dr. Ghassan, as you mentioned, for TKI, is there still for first line, as you mentioned? I mean, outside of COVID, if we are in the, inshallah, in the normal situations, how will is for those patients need, I mean, still get, again, still has a window for TKI? For whom those patients?
Well, remember, they can be all patients, and this is independent of COVID. I put the COVID story only for the scopes and for the intravenous, but even without COVID, TKI still have a role. Because remember, we don't know yet the answer if it's going to be a combination or a sequence. And so I would say the TKI are there to stay at the moment, and I would not necessarily take them out totally as an option per se. Personally, a perspective that I've heard being done and is totally reasonable because of the concern about the ADA, skip on the atezolizumab, give lenvatinib as first line, followed by pembro as second line, is totally reasonable.
Dr. Ghassan, for just Dr. Mirvat, I have a question regarding cholangiocarcinoma. You know, there is no much, things in the cholangiocarcinoma. What regarding the NGS and to request for those patients from the beginning to tailoring those patients who is benefit from the chemo, immuno, targeted therapy? What is your practice?
NGS should be done on cholangiocarcinoma patients, not even 100%, 150%. In other words, even if patient walking down next to your clinic and they're about to enter and you hear the word cholangiocarcinoma, you do NGS even before you talk to them. Because without that information, you'll not be able to serve people right. And remember, it takes a while to get the results back. So you don't want to wait until you need it, because at the 11th hour, it's going to be a problem to get the results in time. So please, always, next generation sequencing is a critical component. A pathology report without the next generation sequencing in cholangiocarcinoma is considered an incomplete report.
Thank you. Dr.
There is
Prof.
an
Majdi?
interesting question. There is an interesting question from the hepatology team. A child score was done for hepatic patients and varices and not for HCC. How we still use as a main staging for Ghassan, please?
That's an excellent question. And I confess that I'm as responsible as many other people. This happened 20 years ago. We were in Houston for what's used to be called the East-West liver meeting. At that time, we had a long discussion, not to call it an argument, to find out what will be the best way to evaluate the extent of cirrhosis. We could not settle to anything because, as we know, there are too many scores, enough that we don't know which one to use. Almost every city has its own score. And we settled ultimately to the Child-Pugh for no reason except that simply this is what we settled to. But you're absolutely right. Whoever asked the question, there was not a single patient with liver cancer within the Child-Pugh and Turcotte evaluations that happened. But however, we settled to it. And please, I urge everybody to really have a good understanding of it. That's more important. The Child-Pugh is not a choice of a B or A or C as if it's like an ice cream flavor. It is actually a exponential curve, not even linear. It's not like A go to B to C like this. It's a long line forever from Riyadh to New York, back to Riyadh around the earth, and still A. And then B is a kind of a curve down, and C is a shoot. Your job is to keep the patient on the long line of A. That's really the most critical component.
Dr. Ghassan, regarding in HCC.
Repeat one more time, please, Dr. Salawi.
Role of SBRT and TAIR in HCC.
Great question. So no doubt that the TARE and SBRT are great efforts that were led by mainly Dr. Salim from Chicago at Northwestern. And if anything, never compared positively to any other therapies. The idea was, can we move BCLC-B therapies like TARE into BCLC-C? It did not work. You remember many of those studies that were negative. The smart thing now, which I give a lot of credit for our colleagues in China, which was reported 2 years ago in JAMA Oncology, what about if we bring the local therapy to systemic disease rather than the other way around? And as such, there has been efforts already looking into what is induced chemotherapy inside the liver plus systemic therapy. The interesting part is going to be, can we do TARE plus local therapy plus systemic therapy for patients with metastatic disease? This is yet to be done, and we'll do it from there. But at the moment, the application is applicable. But please, I urge everybody, if there is disease outside the liver, TARE does not work. This is systemic therapy, because we have great studies and great outcomes that will help patients, as we discussed today.
I would like to thank all the speakers and the panelists. Sorry, we have to stop at that because we have the satellite symposium. Thank you, everybody, and we urge you to continue in our meeting. Now we will have the satellite symposium sponsored by Lily. It's my pleasure to introduce the speaker, Professor Ahmed Abdelwaris. Dr. Abdelwaris is a consultant medical oncologist and professor of medical oncology at King Khalid University, as well as NCI National Cancer Institute in Cairo. He will give us the topic of management of metastatic gastric cancer beyond the first line of therapy.
Bismillah ar-Rahman ar-Rahim. You are hearing me, Dr. Kandil?
Yes, hearing you, seeing your slides.
Okay. I'd just like to thank Dr. Kandil for this nice presentation of me, and thank the organizer to make me share in this great symposium. And my task today is talking about actually a difficult kind of job, gastric cancer beyond first line. It is even difficult for first line, so you can imagine how much difficult it is in the second line and more. So this is my disclosures, and talking about gastric cancer, where we are standing now, a lot of patients, 70 to 80% present with advanced disease, whether metastatic or locally advanced. And patients with metastatic disease, we have quite good number of them will be eligible for a further subsequent treatment. So it is a challenge to find something for these patients that are eligible for more treatment and eager to have more survival benefit of our interference. So this is the overall survival evolution compared to best supportive care, a discussion we would have last millennium, and it moves from best supportive care of 3 months with just pain analgesics and symptom control to more than like 11 months, and in some patients we said to positive more than 1 year of benefit of survival. So what are the challenges that we are facing? And what we are looking for really, we are looking for a dream second line treatment, which is effective, acceptable toxicity, and can control the symptom. Is there such a thing? This is what we are going to try to answer in our presentation. So a lot of challenges are faced in such patients. We can expect resistant tumor clones after first line treatment. Patients have higher chances for resistant tumor clone. And this makes it difficult to show improvement in efficacy in new treatment too. By default, if you have an effective treatment in second line, it will move automatically to first line. So What's left in second line, of course, is not that effective. So we are looking for more effective treatment in such a situation. So patient with a pre-treatment history will expect more symptoms in this patient, and symptom control and symptom improvement become very important in this patient. They will have like reduced performance status, malnutrition, comorbidities that has been there before and become more apparent now, and variety of symptoms. Early on, they can have indigestion, nausea, vomiting, dysphagia, postprandial fullness, loss of appetite, sometimes hemoptysis, and of course, loss of weight. And this can be progressive later on in peritoneal affection, leading to obstruction, bleeding, and evident nutritional deficiency, which is shown in trials that patients with more loss of weight will have less chance to respond to treatment. And this is explained the need for rapid tumor control to get the patient in shape and to receive a second line treatment. Patient with pre-treatment history, of course, will expect reduced performance status, and tolerability will become an issue. And we really need treatment that with acceptable toxicity profile. We don't have treatment with no toxicity, but having a toxicity profile that doesn't affect the performance of the patient and the quality of life of the patient is a mandatory in such patient. So with all of these challenges, do we really need to continue on active treatment beyond first line, or just stop? So that has been answered in this nice presentation of Royal Marsden Hospital meta-analysis published in 2016. And what they did is that they compared patients that received second-line chemotherapy to patients with supportive care only. And it showed clearly that patients that have active treatment live more than the other patients. So that answered our question that we should try to get our patient the dream second line that we talked about, effective, acceptable toxicity, and lead to symptom control. So what we are having as options in this situation, we have chemotherapy, single agents, and a combination of chemotherapy and anti-HER2, and the patient with chemotherapy and anti-angiogenic factors. So let us just see what we have as second-line chemotherapy. We're going to talk about three approaches: irinotecan, taxanes, and platinum reintroduction. So for irinotecan, for docetaxel as single agent, that was tested in the COGAR-2 trial, comparing docetaxel in previously treated patients compared to best supportive care. What we have is response rate of docetaxel is around 7%, and it was having a grade 3 neutropenia in 15%, while febrile neutropenia was only 7%. However, there was a survival benefit of this patient, was overall survival from 3.6 months improved to 5.2 months, and it was statistically significant. Moving to comparing the role of irinotecan to the taxanes that was in the WG4007 trial. Patient also pre-treated patient. Overall response rate was 20.9 for the taxanes, paclitaxel, compared to 13.6 in the irinotecan, and the curves of survival were overlapping. There is no difference in overall survival for 9.5 months for the paclitaxel versus 8.4 months for the irinotecan. And it was not a statistically significant difference between both. So that was equal. How about the platinum reintroduction? That was like brought in many trials. One of them in this Higuchi et al. Team published in 2014, and it was comparing cisplatin irinotecan versus irinotecan. And it was actually showing improvement in the progression-free survival. However, going deeply in the analysis of this trial, and what they did, like the patient was stratified, the patient that have received platinum as first line before, so patient compared to patient with no cisplatinum included in the first line. So it was clearly shown that only patient with cisplatinum, no cisplatinum in first line, receive the combination. This is the only group that have the benefit from the combination of irinotecan and cisplatin. So this should be kept in mind whenever we want to reintroduce platinum. It will not be working well in patients that have either oxali or cisplatin in the first line, as in FOX, for example. So second-line chemotherapy is effective, as shown in different trials, COGAR, Korean, and the AIO study, and it was showing a median survival benefit of around 5 months as median. So which patient subgroup analysis showed that they can respond to treatment, patient with good performance as expected, and patient with prolonged disease-free survival after first-line treatment. That's the most patient that can get the best response from second-line treatment. So the conclusion of the first-line single-agent chemotherapy that it gives a modest survival benefit is around 5 months. Paclitaxel, dosi, irinotecan are all appropriate options. Benefit is greatest in patient with performance 0-1 and progression-free survival equal or more than 6 months. So let us move to another category of treatment, which can be an option for these patients, chemotherapy plus anti-HER2. We know that HER2 expression is used as a marker for response in first-line treatment, and it showed that patients with HER2 positive disease can benefit from adding anti-HER2 to the conventional chemotherapy and gives overall survival benefit. How about second-line treatment? This is in the TITAN trial, and it just tested patients who have HER2 amplified gastric cancer. Good number of patients, 261, with lapatinib, which is an anti-HER2 oral treatment, plus paclitaxel versus taxane paclitaxel. And that was their analysis. And as you show that this is the intention to treat population, showed no much benefit. And if you go to subset analysis of patient with just +1 or +2, there is no benefit. Only in patient with immunohistochemistry HER2 positive +3, there is only one that can benefit from this treatment. This should be kept in mind because the patients that are going to benefit is like 10 to 15% of all patients that are eligible to second-line treatment. So moving to the last option of these patients, which is a chemotherapy plus anti-angiogenic. So vascular endothelial growth factor is very important driver for proliferation and survival and migration of the cancer cells, and stimulation of these receptors lead to more aggressiveness of the gastric cancer and the tumor cells to migrate and proliferate. So it was very logic to try to block this receptor. And one of our drugs that can be anti-VEGF is ramucirumab. It is a humanized monoclonal immunoglobulin 1 antibody binding to VEGF receptor 2 and blocking the activity of this receptor. So this drug has been tested as single agent compared to best supportive care in patients with platinum-based chemotherapy progression. And they were randomized 1-to-1. This is the overall survival and progression-free survival. It was positive study and statistically significant proven benefit. And this is the conclusions of the author. Progression-free survival improved from 2.1 months to 3.8 months for the ramucirumab group, and other ratio is very convincing with significant p-value. Overall survival also showed improvement to 5.2 months from 3.8 months. Disease control improved from 23% to 49% at 1 year. And the toxicity was very low, and grade 3 neutropenia was hypertension, was only 8%. So there is no much added toxicity to the placebo group, and the toxicity was actually manageable toxicity. The same drug, ramucirumab, was tested in combination with the taxane in a randomized fashion in the Rainbow study. And the endpoint of this study was overall survival. And the patient eligibility was patient with unresectable advanced tumor metastatic post first-line treatment. This is the progression-free survival of this trial, and you can just notice that there is separation, nice separation of the curve from the early beginning after 2 months, and actually it was showing a positive progression-free survival benefit of 4.4 months compared to 2.9 months to the single agent group. The same happened for the overall survival, nice separation of the curve, and improvement of the overall survival from 9.6 months versus 7.4 months to the single agent group. And the 6 months overall survival was 72% for the combination versus 57. 12 months was 40 versus 30. Very much good results for a second line treatment at when you have like 40% of your patient live more than 12 months. This is the overall response rate. There is no much of a complete response. This is much expected in a second line. We have partial response of 27% and stabilization of disease in 52%. This is very good for a second line treatment in pre-treatment patients, and that was statistically significant. If we go to the subgroup analysis, interestingly, it was much expected that patient with better progression-free survival, more than 6 months, was having good benefit, and the patient less than 60 years, and we expect that for the comorbidities. And this is very interesting. Weight loss less than 10% is making a good prognostic indication for the benefit of this treatment. So we have to keep in mind that we have to keep the patient in shape to receive this second line treatment. If we go again to a subgroup analysis, the GE junction was better response, and patient, interestingly, that received 3 drugs in the first line was having more chance to respond. And I can just comment on that probably this is the patient that have good performance that tolerated 3 drugs, and they're still having to go to the second line. Patient with intestinal type compared to diffuse type, this is very much understandable because of the aggressiveness of the diffuse type. And the number of metastases, of course, is less than 2 is better. And no peritoneal metastasis, and patient that has gastrectomy in the initial treatment. And that's very much understandable because that will decrease the local symptoms, the dysphagia, the dyspepsia, the hematemesis, all of this decreased without having the tumor in place, the primary tumor. So as regard the adverse events, many adverse events we can expect with adding chemotherapy to the anti-VEGF. And it's mainly neutropenia, leukopenia, hypertension, abdominal pain, and fatigue. The incidence of grade 3 febrile neutropenia was interestingly similar in both groups. So the quality of life has been improved in patient receiving the combination, and that explained by the patient who responded to treatment. We will expect with the response that they will have better quality of life. This is the conclusions of the authors. Progression-free survival has improved in the Rainbow trial with the combination from 2.9 to 4.4 months. Overall survival improved from 7.4 for the single agent ramucirumab to 9.6 in the combination. And also the response rate improved from 16 to 28. There is increase in toxicity of the neutropenia, different grade, but febrile neutropenia is the same, and also in the hypertension toxicity. So this is a data that I want to share with you. What is the trend of the use in the routine practice of the second line treatment in patients have HER2 positive or HER2 negative? So that's in the first one above, is patient received post-progression trastuzumab, and the trend is not increasing over the years. Similarly, polychemotherapy in HER2 negative and HER2 positive is also not recommended, or in routine use, it is not increasing, or it is just a stable use over the last years. Monochemotherapy, it improved a little bit, but this is now in plateau, especially in patients with HER2 negative disease. How about the anti-angiogenic? Actually, this is the only one that is showing increase, whether in single agent or in combination with taxane in the routine use. So the trend in the routine use is to use more of the anti-angiogenic plus chemotherapy in second line setting. Reintroduction of the platinum was not a good idea, and it was not used increasingly over the last 1 decade. So that's the conclusion of the second line options in gastric cancer. We are going to talk about need of biological marker. What % of patients, if you have like 100 patients that are eligible for second line, how much of them can go to all of this? What is the overall survival benefit proved in randomized clinical trial? What is the trend of usage? So let us just see the table. The need of biological marker, definitely with chemotherapy, we don't have biological markers for this, paclitaxel or irinotecan. And till now, we don't have a biological marker for anti-VEGF, but certainly we need to have a biological marker when we want to use anti-HER2. And remember that only 10 to 15% were having positive HER2 plus 3. So that should be kept in mind. And it is not effective in patients that neither have like 1 or 2 pluses HER2 expression. The percentage of patients, if you have 100 patients who are eligible with good performance and satisfying your eligibility, you can use, of course, the single agent chemotherapy or the anti-VEGF and the chemotherapy combination. You need to have the HER2 expression to go for this patient, okay? So overall survival benefit, it is modest for the single agent, around 7.4 for the taxane, 4.2 for the irinotecan. The combination on the pacli and ramucirumab give like around 9.7 months. And the anti-HER2 plus chemotherapy in patient with HER2 positive plus 3 is good, and it gives 10 months survival. What is the trend of usage? This is the chemotherapy, either single or combination, is stable trend of use, thus increasing, and this is stable. So we need symptom control for this patient and nutritional support. And remember that we have one trial by Gillis published in 2014, and patients that have rehabilitation with exercise and nutritional counseling have better quality of life. And this interesting data that has been presented in ASCO 2020, and they have like a post hoc analysis of the different trials, use the anti-VEGF plus chemotherapy, and the relation of the loss of weight to the prognosis of the patient. And patient with less than 3% loss of weight has the most benefit in single agent and in combination with the chemotherapy when the anti-VEGF is used plus chemotherapy. So this should be kept in mind. Try to keep your patient in shape before you start the second line of treatment. If you go to gastric cancer beyond second line, we have some options for these patients. Immunotherapy has been tested, and trifluridine tipiracil has been also tested in this third line setting. So this is the Attraction 2 trial. The design is simple, immune versus placebo. Patient received two or more than 2 lines of treatment. Primary endpoint overall survival, and secondary endpoint is progression-free survival, among others. And it was a positive trial, giving improvement from 4.1 months to 5.6 months again, and it was statistically significant. In the keynote of 559, it's a pembrolizumab trial. It is a single-arm trial, phase 2, with patients with same eligibility as before in the NIVO, patient with prior treatment with 2 or more lines, and treatment was given till disease progression, and the overall survival median was, of course, good, 5.6 months. This is the TAGS trial that explored the benefit of trifluridine tipiracil in gastric cancer, and it is a straightforward randomization between TAS-102 plus best supportive care versus placebo versus best supportive care. And this eligible patient received many lines of treatment, and the point was a primary overall survival, secondary progression-free survival, and safety. Other secondary endpoint was overall survival and others. And it was also a good study, and it was statistically significant, proven to improve the median overall survival from 3.6 months in the placebo group to 5.6 months with a gain of around 2.1 months, and p-value very impressive, 0.0003. So the conclusion of my talk, this is the NCCN guideline, and you can just be lost in this recommendation. They have put everything from category 1 to category C, and everything is there. Anti-VEGF plus chemotherapy, anti-VEGF alone, irinotecan. But how we can go through all of this? What is our guidelines? What is the roadmap? So my first advice, get your patient in shape. Involve palliative care with you. They have a lot of maneuver that medical oncologists are not like very experienced and very knowledgeable about it. Nutritional assessment and nutritional support is also very corner side, and this is very important a step in management of this kind of patient. Please deal with the inlet and outlet obstruction. Patient will continuous vomiting. They will not ever be able to get chemotherapy, anti-VEGF, or name it. I mean, so think about stenting, diversion, dilatation. involve your colleagues from gastroenterology surgery and gastroenterology medicine to help you in that. Pain control, of course, patients who have pain, whether it is related to the primary or the secondary tumor, they can benefit from like localized radiation therapy, for example, to an area that's causing pressure on nerves, and pain medication should be there, and patients shouldn't be allowed to have much pain. And believe me, they will never be complying or tolerating your treatment. Of course, managing the comorbidities, because they might be the source of the symptoms and not the tumor. So keep attention to what is the patient actually having as baseline comorbidities. So remember that we have, okay, this is my last 2 slides. So remember that we should try to treat all eligible patients, and keep in mind that the word eligible, because of non-eligible patients shouldn't be treated. So how to choose our patient? This is the Royal Marsden and the Easter Oncology Group, cooperative group, independent prognostic factors. And we can just summarize it with good performance status patients, patient who is progression-free survival equal or more than 6 months, less than 3 metastatic site, hemoglobin above 10 or equal, and alkaline phosphatase more than 100, CEA more than 50, less than 50, and alkaline phosphatase less than 100 is a good prognostic indication that at least your patient can benefit. And choose from the approved regimens. Single agent chemotherapy, Pacli, Dosi, irinotecan are all appropriate options. Chemotherapy plus anti-HER2 is only working in patients with +3 HER2 positive. And the chemotherapy with anti-angiogenic in randomized control trial compared to chemotherapy alone improved overall survival significantly. In 3rd line, you have the options of Nivo, Pembro, and TAS102. With this, I end, and thank you for your attention, and I'm ready for your questions.
Thank you, Dr. Ahmed. We have several questions. Thank you for your elegant presentation. One question: if the patient receives in the 1st line FLOT chemotherapy, what are you going to give him in the 2nd line?
Well, this patient in FLOT, he has the fluoropyrimidine, the oxaliplatin, and the taxanes. Patient, if they have like fitting the eligibility, I advise to do the HER2 status. If he is having HER2 positive, he can receive taxane plus anti-HER2. If he is HER2 negative, I'll go for the anti-VEGF with chemotherapy.
What about FOLFIRI ramucirumab as the Ramirez trial?
Well, if the patient can tolerate the combination, but remember that the FOLFIRI, if having like the fluoropyrimidine and that was failed in the 1st line. So irinotecan and ramucirumab was not tested, but taxane plus ramucirumab would be a good option. It is a call, you know. Irinotecan, when it has been compared to head-to-head to taxanes, although overall survival is equal, but the response rate is low in the irinotecan.
If you have a patient with coagulopathy, have DVT, for example, this is common in patients with gastric cancer. How can you give him the ramucirumab?
Well, I have to anticoagulate him, watch him closely. It is not like absolute contraindication. I'm looking where is that thrombosis is, and depends, like if he has like an area that's like pulmonary embolism, for example, extensive, I would be very much cautious on using this drug or others. But if it is a DVT, I'll just control it by anticoagulation and go ahead.
Yes, we usually start for 2 to 3 weeks anticoagulation, and then we can use the ramucirumab.
Exactly.
One of the side effects is perforation, and some physicians are afraid because of this. Can you comment on this, especially in those patients with peritoneal metastasis? Do you think any contraindication for ramucirumab for these patients?
Well, that's a very good question and very much worried. Patient with extensive peritoneal disease, I'll be very cautious to use anti-VEGF, whether it is a gastric or colon or anything. But minimal, like 1 or 2 in the seen in the CT scan or the PET scan, I will go ahead. So be cautious. Extensive peritoneal disease, I think you have to be very cautious. Patients are very much liable for perforation.
Yes, especially with the obstruction. If there is obstruction, I think you should avoid.
And if you remember that analysis, the subgroup analysis, patient without peritoneal disease has more benefit. That's explained that there is low, and of course it is not the perforation. Peritoneal metastasis can lead to obstruction, and that's also a big problem. The obstruction of this patient cannot be resolved surgically because it is diffuse. If you improve one obstruction, it will obstruct in another area. So that's very bad sign.
For the sake of time, thank you, Dr. Ahmed Abdelwaris. We'll have 5 minutes break, and then we'll start the next session, breast cancer session. Thank you for all speakers and attendees. I'll leave the phone to Dr. Abdelaziz.
Thank you, Dr. Majdi, and thank you, Dr. Walid. And for sure, thanks to all the speakers for this reachful and really up-to-date presentation regarding the GI cancers. As Dr. Majdi said, we're going to start, inshallah, the next session in about 5 minutes. I will introduce the speakers. Meanwhile, it is breast session, and our chairmen we're going to be Dr. Isam Murshid, attending consultant, medical oncology, Prince Inflammatory Medical City. He's one of the senior medical oncology in nationwide. Also, Dr. Hisham Al-Ghazali, who is a professor of oncology at Ain Shams University in Egypt. And my colleague, Dr. Talib Bouhrega, who is attending consultant in medical oncology in Prince Sultan Military Medical City. I will leave the podium for them. They can, inshallah, start within 5 minutes. I think all of them online.
Abdelaziz, فين رحت؟ سلام.
You are online now, guys. You want to just wait till 5:15. Okay.
Because it's Maghrib prayer. I think they need to pray Maghrib and to come back.
Yeah, 5:15.
Announce the adhan. We are online or we are offline?
Yes, we are online.
So let's go off the camera then better. السلام عليكم يا دكتور هشام، كيف حالك؟
وعليكم السلام ورحمة الله. دكتور عصام، ازيك؟ اخبارك ايه؟
مرحبا بك.
الله يخليك.
يلا خلينا نروح نصلي ونرجع.
طيب اوكي. يعني 5 minutes؟
يعني
ازيك؟
30 ثانية نختصر في الفاتحة شوية.
It's good to see you.
ان شاء الله. طيب يعني هنبدأ بعد 5 دقايق يا دكتور؟
5 minutes. Oh yes, بإذن الله. Thanks for joining.
ليا الشرف.
شكرا.
Okay, I think we should invite all the panelists for the coming session. It's already 5 minutes past. So if Prof. Al-Ghazali will join us, and Talib. Talib is offline. Okay, Dr. Abdulaziz, shall we start or?
I just want to check with if the next is ready.
The next speakers, I can't see Ahmed Al-Shehri's icon. Ahmed, are you on?
Nikki, not yet. She's joining now.
Okay.
Can you?
And Dr. Levette.
السلام عليكم.
هلا أحمد. السلام
هلا
عليكم.
عصام، كيف حالك؟ أخباركم إن شاء الله طيبين؟ إيه موجود، الله يحفظك. كلام
ممتاز. Father Levette وشريف. We can start with Ahmed on board, and Dr. Ghazali, I think he's also on board. Yeah. Dr. Hisham.
I think we can start now. It's okay.
Okay. بسم الله الرحمن الرحيم والحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening. It's already evening. I was prepared to say good afternoon, but it's already evening. Good evening, ladies and gentlemen. Special thanks to everybody who organized this event, to Prince Sultan Medical Military City Oncology Department, Dr. Al-Hamid, my colleague, Dr. Mahrous, Dr. Kandil, and Dr. Talib, and everybody else, and for the sponsors and for the organizing company. I will open the session. The next session is about breast cancer. And we have loads of topic actually. It's ranging between HER2 positive disease, hormone positive disease, and bone metastasis. And we have very eminent panelists on board, as well as very eminent speakers. I will start by introducing the panelists and the chairpersons. Of course, we'll start with Professor Hisham Al-Ghazali. Professor Ghazali is a medical oncologist consultant at Ain Shams University in Cairo, Egypt. Welcome, Dr. Ghazali. And Dr. Bouhlega, Talib Bouhlega is a consultant medical oncologist and the future of the oncology department actually in BES MMC, who will also chair the session with us. And we have eminent speakers. I would just invite Dr. Ghazali to introduce the first speaker until we have Talib on board. Professor Ghazali, please go ahead.
Thank you very much, Professor Assam. It's very, very nice to be in a very important meeting like this. The goal is to be very interactive, and I'm very happy to have an eminent professors in the panel and eminent professor in the faculty. And this is my honor and the pleasure to introduce one of the pioneers of breast oncology, Professor Dr. Ahmed Shehri, a consultant oncologist and assistant professor in King Faisal Hospital. And it's very nice to hear from him a very important topic about the TDM1 in early HER2 breast cancer. Is it a time to take the lead? So we will see the answer now from Dr. Ahmed Shehri.
Thank you, Prof. Al-Ghazali. I would like to thank our colleagues in Military Hospital Riyadh for this arrangements of this great gathering and educational event. Just give me a minute just to share my slides. Do you see the presentation?
Yes.
Excellent. So I'm supposed to talk about TDM1 in early breast cancer, and the answer to the question which was presented at the beginning, TDM1, should it take the lead? I would say yes and no. This is the short answer. So we'll go in details. We know that HER2 positive breast cancer represents like roughly around 20% of invasive cancers, and usually HER2 positivity harbors like an aggressive behavior and worse clinical outcomes as compared to other subtypes of breast cancer. And we know since the introduction of different anti-HER2 targeted therapies, there have been a dramatic change in the prognosis in HER2 positive breast cancer over the last 2 decades, whether talking about advanced and early settings of HER2 positive breast cancer. So TDM1, as we know, it's an antibody drug conjugate composed of humanized monoclonal antibody trastuzumab, covalently linked to a cytotoxic agent, which is in this case a tubulin inhibitor. And the efficacy of TDM1 have been established in the metastatic setting of HER2 positive breast cancer, whether talking in earlier lines or later lines of management of metastatic HER2 positive breast cancer. And there have been an improvement in progression-free survival, overall survival, with favorable safety profile when we compare it to the standard chemotherapy have been tested head-to-head too. Based on the efficacy and safety of TDM1 in metastatic breast cancer, several studies have been conducted more recently to address the role of TDM1 in early setting of breast cancer treatment. Having said that, there have been several studies, and the different studies of interest that I will talk about in this